Hello, good morning. The people on Zoom, could you, one of you, just say something, please?
Good morning. Did you hear me?
Yes, we hear you. Thank you.
Thank you.
Check, check, testing, testing, testing. Testing, testing. I've been asked to advise these persons, drivers of 87622JJ, that you're parked illegally, if I want to use that word advisedly. You're improperly parked. I'm sorry, you're improperly parked. 87622JJ, you're occupying two spaces, and I understand that this place is going to be full, so you just need to. Sorry? Yeah. And also the driver of 5885HM. Both vehicles are occupying two spaces, and we just need to park properly, please. Thank you. Let me just repeat the numbers. License plate 87622JJ and 5885HM. Thank you very much. I'm asked to repeat the license plate numbers. 87622JJ and 5885HM. One more time. 8762JJ and 5885HM. All right, Greg. I see you looking. Okay, fine. Thank you.
man. The big man at the meeting fit today. You know, I want to cheer this. All right. Why don't get that one up, sir? All this? Yesterday, put this on.
Morning, everyone, and I want to welcome you to the 11th Annual National Health Research Conference that is taking place starting today into tomorrow, November 19th to 20th. I'm your chairperson for this morning, just for a brief period. I'm Dr. Bisesa McKenzie, Chief Medical Officer for Jamaica. We're going to start with the national anthem, and therefore I'll ask persons in the room to stand, and an instrumental will be played. Thank you. Please be seated. We always feel so refreshed after we hear the national anthem. And so we're going to move straight into our invocation, and I'm going to invite Mrs. Sonia Parchment, Senior Secretary in the Policy Planning and Development Division of the Ministry of Health and Wellness, to give the prayer.
Good morning, everyone. My name is Karen Samuels, and we're going to pray. Can everybody hear me? Our sovereign Lord and Savior, we thank you for today. Thank you for health, strength, and sound mind. God, we praise you that you woke us up this morning, a day like today where we have life. What a privilege it is to see another day. We thank you. God, right now we place this meeting of the 11th Annual National Health Research Conference in your hand. Thank you for guiding this meeting. We ask for a special blessing upon the program, the plans, the activities, the discussions. Bless this two-day conference, Lord. And thank you for everyone who are in the planning process. Lord, we continue to ask for wisdom, for your direction, especially at this time with the COVID pandemic. God, as the theme says, the COVID-19 experience, adjusting to the new normal. We lean on you, knowing that you know all things, that you're the all-wise, omniscient God, the omnipotent Father who is all-powerful, and the God who is omnipresent everywhere. And we believe that as we go on through this new norm, that we will adjust and adapt and learn from it. God, it isn't easy mentally, financially, and even health-wise, but we put our total trust in you. We ask for continued strength and sustenance as we go through this. We lift up all those who are affected, all countries, or healthcare workers who work so tirelessly. Give them sustenance, Lord. God, right now we thank you for the Minister of Health and Wellness, the Permanent Secretary, and all those who lead, who are in authority. God, give them divine wisdom. We hold on to the promise that you will never leave nor forsake us, and knowing that you are with us. And we know when you're with us that all shall be well. Continue to bless us, Lord. Bless this day and make this conference successful in every way possible. Guide and protect everyone, we pray. This in no other name but the name of Jesus Christ, our Lord. Amen.
Amen. So again, I want to thank everybody for being present. I want to welcome you. This is a very, very important event in the Ministry of Health and Wellness calendar. Now in its 11th year, and for the first time being held virtually, the conference continues to provide a platform for hundreds of participants to benefit from outstanding research in various areas related to health and wellness. These presentations have far-reaching impact as Jamaica's health system becomes more responsive to the needs of the population based on its health profile and determinants that are recognized from work carried out by our own local researchers. We are confronted with new and emerging diseases to which our cadre of health professionals must respond in a timely and efficient manner in order to safeguard the health of the population. Collecting and analyzing data that is representative of our population paves the way forward towards relevant and effective policies. This year's conference theme, the COVID-19 experience, adjusting to the new normal, is of course tied to our present situation, where for the past 9 months, Jamaica and countries across the world have had to change how we live and how we do business, with many more how we live and how we do business as we face this ongoing public health challenge. COVID-19 has taught us many lessons, and we have many more to learn as we analyze the data that is there for now and for the future. The COVID-19 experience has again highlighted the important role that health plays in every facet of the society. We dare to say that health is a foundation of any society. As penned by Winston Churchill, who once said, "Healthy citizens are the greatest asset that any country could have." The documentation of this period in history, the analysis of our public health responses and the outcomes, the effect of the disease on our population, and the impact of our clinical management are only some of the areas that will form rich ground for research now and in the future. I am confident that this 11th staging of the National Health Research Conference will be a success, and that the presentations on interventions will inform our best practices. I want to congratulate the organizing team that despite all that we are going through, and this team in particular is critical to the work that we are doing in terms of analyzing the data and our day-to-day response on the ground for COVID-19. So it is truly a Herculean effort that they have put in, and I must congratulate them and recognize this tremendous amount of work for what I know is going to be a great conference, and of course what promises to be another great year for research. Thank you. Now move on to the other greetings that are going to come from some of our very important stakeholders. And I am going to list the order in which we're going to have these greetings, and I'm going to ask the persons just to come on one after the other. So first I will have Dr. Bernadette Theodore Gandhi, representing PAHO WHO. Dr. Gandhi is our country representative, and just want to say again, recognize the work of PAHO in supporting us in our response to COVID. This will be followed by Dr. Joy St. John, who is the Executive Director of CARFA. Again, CARFA has helped us so much and provided so much support, not just for Jamaica, but for all the countries of the Caribbean and the CARICOM region. And this will be followed by Dr. Veruj Dede, the Director of the Caribbean Regional Office of the CDC. And also CDC continues to play a very important part in offering tremendous assistance and boosting our capacity to respond to COVID. So in that order, Dr. Gandhi, Dr. St. John, and Dr. Dede, they will bring their greetings. Thank you.
Good morning. I hope everyone can hear me. Well, this is not Dr. Gandhi. My name is Audrey Morris, and I'm representing Dr. Gandhi. I'm pleased to bring you greetings this morning on her behalf. So, Madam Chairperson, Dr. Bisisa McKenzie, Honorable Minister of Health, Dr. Tufton, Dr. Varu Dede, Director of CDC, Dr. Joy St. John, Executive Director of CARFA, other distinguished guests and participants in Jamaica and elsewhere. The Pan American Health Organization congratulates Jamaica's Ministry of Health and Wellness and all stakeholders on this 11th staging of the annual National Health Research Conference. The theme of this year's conference, the COVID-19 experience, adjusting to the new normal, is very timely, as this pandemic has reiterated the benefit of timely collection, collation, and analysis of relevant data to provide information and evidence for decision making and action in the field of surveillance, case management, and prevention and control. The conference's objectives fit squarely into the core work of PAHO, as the second of our 6 core functions is to shape research and stimulate the generation, dissemination, and application of valuable knowledge. We're therefore pleased to support and to be a part of this undertaking. The PAHO WHO strategy for universal health recognizes that a health system that works for all must systematically and sustainably strengthen national information systems for health. The health system must also practice decision-making processes that consider ethical, cultural, gender, and national perspectives and are guided by evidence. PAHO is committed to provide technical support in building a research agenda that prioritizes the health challenges of today and those that are projected to result from the individual, community, and economical practices. In a spirit of equity, let us be sure to remember the most vulnerable who may require targeted support in achieving their best health and life outcomes. Adolescents and youths, older persons, low-income households, people living with disabilities, as well as minorities. The commitment of the Ministry of Health and Wellness to sustaining this national initiative is highly commendable. On behalf of PAHO and the World Health Organization, I am confident that this will be an informative and productive conference and that the discussions and recommendations will inspire positive change in the health and lives of all Jamaicans. Thank you.
So thank you very much, Madam Chair. CMO Dr. Jacqueline Bissessar-McKenzie, Dr. the Honorable Christopher Tufton, Minister of Health and Wellness. In her absence, Dr. Bernadette Theodore Gandhi, Pan American Health Organization, World Health Organization representative. In Jamaica, Dr. Varu Dede, Director, Caribbean Regional Office, Centers for Disease Control and Prevention, CDC. Ms. Karen Samuels, Administrator, Financial Management Division, Spiritual Wellness Committee, Ministry of Health and Wellness, and thank you for that prayer. Other ministry officials, delegates, greetings. I am honored to have been asked to bring greetings on behalf of the Caribbean Public Health Agency. CARFA is very proud to have collaborated with the Jamaica Ministry of Health and Wellness in the development of the National Health Research Conference since the inception. And we are even prouder of the way this conference has developed, with a 7-fold increase in attendance in the intervening years. 2020 has been all about big paradigm shifts in the world order, in the mundane ways of living, in the ease of conducting economic activity. But the biggest paradigm shift has been the growing realization that every action has to be taken with a public health protocol in mind to protect the health of oneself and others. Life on planet Earth has focused on how to make things easier to make money or have fun. COVID-19 made the world stop and revolve around health. This is a critical juncture for public health. The role and value of public health professionals are being highlighted in every walk of life. So, I applaud the topic of this conference for its relevance and applicability, and for its recognition of an amazing body of work in this small corner of the world by the public health teams all across the CARICOM region. I really want to say thanks to all who serve in the health field. Many have given their lives and lost their health in the process around the world. Sadly, although our deaths are relatively few, we have lost colleagues in health too. I ask those gathered here to say a silent prayer for those we have lost and for the safety of those of us who remain. We have had many achievements as a region in our response to COVID-19, but these are not without challenges. The pandemic is not over, and therefore we must continue to fight to keep our communities safe. This year's conference, the COVID-19 experience, adjusting to the new normal, is therefore an opportunity to highlight considerable ingenuity, public health technical skill, and innovation, which the Caribbean and Jamaica in particular have demonstrated. But what has happened with the health systems has not just been about the pandemic. As you continue with this research journey, be mindful that amidst COVID-19, the Caribbean still managed the myriad of other existing public health emergencies, including natural disasters. As well, this pandemic has put into the spotlight many issues that should have been addressed in order to curb the devastating impact of this virus. These include mental health, NCDs, health expenditure and financing, sustaining our human resources for health, and ensuring our healthcare system resilience. I say that this pandemic has a silver lining. Well, many really. The first is that the Caribbean has shown the world that leadership by the heads, regional solidarity, and multi-sectoral coordination can literally save lives. Second, the health leaders, the ministers and the CMOs, and the health workers on the front line have demonstrated how resourceful and brave they can be. And third, the people of the Caribbean lands have reinforced their love for life, their families, and their communities. I am banking on the outcomes of this conference contributing to adequate planning and policy development that can help the region to continue with the gains it has made even in perilous COVID-19 times. CARFA wishes to commend the Ministry of Health and Wellness and the hardworking conference team for their continued and dedicated commitment to advancing research of public health priority in the region. For although this was not possible for an in-person event, you, the organizing team, have recognized the need to have a virtual event. And in the same vein, staying true to the conference theme of adjusting to the new normal. I thank you, and I wish you all a successful conference. Over.
Thank you, Chief Medical Officer, Minister of Health and Wellness, Dr. Jacqueline Besaso-McKenzie, Chair of the conference, Honorable Minister of Health and Wellness, Dr. Christopher Tufton, Dr. Joy St. John, Executive Director, Caribbean Public Health Agency, Dr. Audrey Morris, Regional Advisor for PAHO, on behalf of PAHO representative in Jamaica, Dr. Gandhi, chairs of the various sessions, presenters, organizers of this conference, colleagues, good morning, everyone. It is my distinct honor and privilege to bring greetings and congratulate the Jamaican Minister of Health and Wellness on behalf of the U.S. Centers for Disease Control and Prevention, CDC, for organizing this 11th National Research Conference 2020. We first commend the ministry's efforts in combating and containing the pandemic in Jamaica. A great deal of lessons can be learned from the Jamaica experience. CDC has had a long-standing collaboration with the Ministry of Health and Wellness, starting from influenza to HIV to Zika to public health preparedness, and now COVID-19. This past October, CDC signed a cooperative agreement with the Ministry of Health and Wellness to support the ministry's efforts in addressing various public health needs. We have also supported PAHO with financial support to enhance Jamaica's national response to COVID-19. Now, the theme of this 11th National Health Research Conference, the COVID-19 experience adjusting to the new normal, is a reminder of the impact COVID-19 pandemic has had on the lives and the livelihoods of many around the globe, including right here in Jamaica. The conference will provide an opportunity for sharing and learning about how the government, the citizens, and all stakeholders have experienced and managed the pandemic. It also provides a platform to discuss successes, challenges, opportunities that are brought forth by this pandemic. There is much that we don't know about this novel coronavirus and the resulting COVID-19 disease. That is why research conferences like this one are so important for us to share new knowledge and disseminate findings on newly emerging and re-emerging diseases. The 4 research areas that will be discussed and covered during this conference are of critical importance. As a new disease, COVID-19 pandemic may be stressful for both children and adults, and so may the public health actions taken to combat it. People could be overwhelmed by what could happen, and it is important that stress is managed in a healthy way, which helps everyone cope and be resilient. The safety and well-being of healthcare workers and public health responders must remain at the forefront in the overall response to COVID-19 in any public health threat. Some steps employers can take to reduce workers' risk for exposure to SARS-CoV-2 include: 1, develop an infectious disease preparedness and response plan. Prepare to implement basic infection prevention measures. Develop policies and procedures for prompt identification and isolation of sick people, if appropriate, and develop and implement and communicate about workplace flexibilities and protections. And finally, implement workspace controls. The scale of the COVID-19 pandemic requires global partnership to identify and implement innovative technology solutions to ensure the most vulnerable among us have access to basic health services. The pandemic has also imposed on the global community to think and work differently and not business as usual. Surveillance around maternal health in the era of COVID-19 is key to understanding the impact of COVID-19 during pregnancy on both the mother and infant and how to mitigate those impacts. We have recently learned of the negative impact the pandemic has had on routine immunization programs in parts of the world, and that will no doubt have negative consequences on people and governments. Yes, there is progress in COVID-19 therapeutics and vaccine, but this should not be and could not be a reason for complacency in the continued implementation of basic infection prevention control measures, wearing masks, hand washing, and physical distancing, etc. And finally, I would like to congratulate the organizers of the conference, and I look forward to learning about the work to be presented and discussed, and I wish everyone a great conference. Thank you.
Thank you to our esteemed partners for those words. And again, just want to recognize the tremendous support that we have received from all these agencies in terms of our response to COVID and generally in the ministry's work. After the keynote, the feature address, we are going to have a break And during that break, we're going to have our feature entertainment, which will be the COVID-19 jingle competition winner. And then this will be followed straight into the scientific session, the first scientific session, which will be chaired by Dr. Spence. We're going to have two scientific sessions today. The first one will be health and wellness. The second one will be mental health. And the first will be chaired by Dr. Spence, our Director of Health Promotion and Protection. And the second will be chaired by Dr. Nadine Williams, our Director of Health Services Planning and Integration. So now we move into our feature address. The Minister of Health and Wellness, the Honorable Christopher Tufton, needs no introduction. And we don't have to be reminded, or maybe we should be reminded, of his zeal for research and for data. I still cannot forget when he just came to the ministry, its first item was, where is the data? What are we going to do, and where is the data to support it? So, and he continues during his period here to stimulate the ministry and to provide the support for the ministry in carrying out important research. There have been several initiatives that he has started and have been working well to provide information for us and our important programs. So I'm going to welcome the minister to the podium now to give us the feature address.
Thank you very much, Madam Chair, the Chief Medical Officer, Dr. Jacqueline Biseso-McKenzie, Dr. Bernadette Theodore Gandhi, PAHO WHO representative, and a representative who spoke earlier, Dr. Joy St. John, Executive Director of the Caribbean Public Health Agency, Dr. Dyke, Director, Caribbean Regional Office, Centers for Disease Control and Prevention, based here in Kingston, Jamaica. Members in the room representing the Ministry of Health and Wellness. Have to mention Dr. Webster Carr, our Chief Epidemiologist, Dr. Simone Spence, and others. And of course, members on, should I say, out in Zoom land. Technology is bringing this event live. So a lot has been said earlier, and I want to just recognize the significance of the contribution of partnerships. The previous three speakers are very critical to the public health agenda that we set for ourselves. And it is through collaboration with the CDC, with PAHO WHO, and of course with CARFA that we are able, I think, to give the best possible public health response to not just the people of the country here of Jamaica, but the Caribbean, the region, the hemisphere, and by extension, the world. So I pay tribute to those organizations who were represented earlier. So life as we knew it 7 months ago, frankly speaking, is over. That's a very swift and simplistic, but nevertheless a truth. We must quickly come to terms with that, and we must adopt, changing our behaviors to suit and survive the new realities brought by the global COVID-19 pandemic. And I think today's research conference, the 11th Annual Health Research Conference under the theme, the COVID-19 Experience Adjusting to the New Normal, is most appropriate. And that is what I think the Ministry of Health and Wellness and the team who drives this conference are in fact doing, with the support of our partners, some of whom spoke earlier. I want to commend our national epidemiology team, Dr. Webster Carr and her team, and the Essential National Health Research Committee, who has put a lot of effort and continue to put a lot of effort, which we will see on display over the next 2 days. Those of you who know me, and Dr. Webster Carr, Dr. McKenzie, sorry, Cesar McKenzie, our CMO, said it earlier, knows that I rarely take a decision an important decision around public health before asking for the data that supports, even if not in a precise way, why that decision is to be taken. And so I am fully behind, fully endorse, fully support any scientifically proven approach to gathering, assessing, and analyzing data to determine trends and to influence conclusions on policy or operations. So I'm very pleased, therefore, that the conference, as has been the case in the past, is set in the context of the essential national health research that supports national development, informs what we do while providing data to improve how we operate and guide the best use of resources. You know, globally, some 53.7 million persons have confirmed COVID-19 cases, with 1.3 million deaths. In Jamaica, up to yesterday, November 18th, we have had more than 10,000 confirmed cases, 230 deaths, with some 54% of those cases having recovered. I want to first of all recognize those who have been affected by COVID-19. First of all, the victims of the virus, and in particular the family members of persons who have passed, the 230. Express our condolences to those persons, but those who have had the experience of the virus and have recovered, and those who have been on the front line responding to this pandemic in a way that I believe should make us proud, because we have risen to the occasion. I say so to those who have been in Jamaica, who are in Jamaica responding, the frontline health workers, but also the supporting agencies. But indeed, I think the world, the region, has also adjusted to dealing with the threat of this virus. We need now, having gone this far, and are now seeing, I would say, some light at the end of the tunnel in terms of a likely vaccine, which will offer some long-term solution or resolution to the threat. But nevertheless, there are many lessons that we have learned, or we need to learn, and the world cannot be the same again, certainly as it relates to infection prevention and control, certainly as it relates to behavior within our natural environment, within our workspaces. And so we need to work to ensure that we maintain and improve performance and response. And in that regard, research represents the fundamental platform on which that sound decisions are going to be made. The most recent Jamaica Health and Lifestyle Survey reveals that 1 in 3 Jamaicans are hypertensive, 1 in 2 are overweight or obese, 1 in 8 had diabetes. Still, many were unaware of their condition and were engaging in behaviors likely to increase their risk of NCDs, including high consumption of sugar-sweetened beverages, low consumption of fruits and vegetables, and low physical activity. This poses a challenge on 2 fronts, and it's all connected, by the way. The COVID theme is connected to the NCD theme, because as you have seen, those are the persons who have been most affected. Firstly, we need to discuss the burden of chronic non-communicable diseases. This is being done by the ministry through a number of initiatives, including our Jamaica Moves program, which emphasizes physical activity, nutrition and routine health checks, as well as, well, importantly, knowing your health status. We have also launched a wellness agenda to include workplace wellness and a national school nutrition policy. I'm very happy to know that we will be tabling that school nutrition policy soon. We are now past committee stage, going now to cabinet, And that nutrition policy will influence what we serve to our children within their school system, within the school environment. Also, the promotion of wellness events. You know, wellness to me is so important because it captures the prevention theme. It's a state of mind. And there are so many things that you can promote that influences the lifestyle, that de-stresses you and that puts you into a zone. In fact, the buzzwords now that are surrounding wellness are things like mindfulness. Spend a little time to meditate, to think about your day, to think about your state of mind, and find the opportunity to do things that stimulates and encourages a sense of well-being. But we're doing things that, on the face of it, don't seem to be clinical in terms of a response to one's state of wellness. So market pop-ups to encourage consuming fresh fruits and vegetables, which is a challenge in a dispensation, in a country, in a region where we have the best tasting tropical fruits and vegetables, where we are blessed with great weather. But if we're not careful, we take it so much for granted. We eat processed foods, branded, manufactured 2 years ago and stored in a tin with significant preservatives that ultimately leads to all sorts of ailments. If you look at cancer rates, for example, globally, it's increasing at a faster rate. And there is a theory behind that as it relates to processed food. So greater emphasis will be placed on these initiatives post-COVID-19. How do we enhance the wellness agenda to build resilience within the state of mind and the physical state of persons and the mental state? The second challenge, that most persons with comorbidities are at a greater risk of more severe illness and death, including COVID-19. Preliminary analysis of data on COVID-19 cases indicates that persons with comorbidities are at a significantly increased risk of death. That is a fact, certainly in the case of Jamaica and in the case of the world. We have looked at the data. The pandemic has also restricted individuals' ability to access routine care. The World Health Organization conducted a rapid assessment involving 163 countries on the impact of the pandemic on NCD services. 77% of countries surveyed reported disruption in NCD activities, while 3/4, or 75%, reported a disruption in NCD services. And it's understandable. The pandemic has caused us to pause, to direct or redirect resources to dealing with the response. And the typical responses have therefore been compromised as a result in the context of limited resources in public health. In order to address this challenge, the ministry launched a public-private partnership in which 8 health centers and 4 private facilities in Clarendon, St. Anne, and Kingston and St. Andrew will provide treatment to approximately 5,000 diabetes and hypertensive patients. So we have now engaged in public-private arrangements. I spoke to this a few days ago in the Parliament, where we have taken 5,000 patients out of the public system and assigned them to private doctors so that they can get their routine care with certain protocols in place, a manual of best practices, a reporting arrangements, that sort of thing, in order for these public patients to get the service in an efficient way, at no cost to them. We pay for it, and at free up support for the COVID response in the public system. Mental illness are NCDs that are often hidden or overlooked due to the silence and stigma. And we in Jamaica are faced with relatively high burden of disease. The Jamaica Health and Lifestyle Survey estimated the prevalence of depression at 14% in the overall population, 10% in men, 19% in women. This is likely to worsen and has worsened during the COVID-19 pandemic, in which Jamaicans are coping with isolation, acute illness, loss, and fear. And this is, again, not just unique to us. In addition, the WHO has reported that the COVID-19 pandemic has disrupted mental health services in 93% of countries worldwide. In order to address this, we here in Jamaica recently launched the COVID-19 Mental Health Response Program to provide support at the community level. And again, it's really about COVID fatigue. That's what I describe it as. And we have to respond as side effect of the restrictions, the COVID restrictions. This year's conference is responding to these challenges, and appropriately so. In addition to a special panel discussion on striking the balance in health and wellness, there are 14 scientific presentations pertaining to COVID-19. We look forward to the sharing of these and other findings and encourage presentations in other forums to ensure that our response is evidence-based and can benefit from local data. Our vision for this event sees us setting research priorities to guide what we do, enacting laws and policies to govern the conduct of research, increasing the capacity of the ministry and other institutions to conduct the research needed for decision-making, and disseminating the results to varying audiences using a number of different research products. This vision is supported by PAHO and the Caribbean Public Health Agency, and we thank them, and is part of our Vision 2030 National Development Plan with the development and implementation of the governance policy and strategic framework mentioned in the medium-term socioeconomic policy framework for 2018 to 2021. The ministry has worked towards this vision through the reinitiation of an essential National Health Research Committee in 2014 and has developed a National Health Research Agenda which has been adopted by a number of stakeholders, including those in academia, in ministries, departments, agencies, and education institutions. Work has also been done on a policy on research for health, as well as on a 10-year survey plan in which the ministry seeks to advocate for funding for large-scale surveys, which are expensive, but which are needed to provide data to guide our national program. The ministry has also launched initiatives to support research covering our National Health Research Agenda, including a Research for Wellness Fund, financed by the National Health Fund to the tune of some 50 million Jamaican dollars annually to support evidence-based policy. And what we have done, basically, I announced this last year in my sectorial, we're setting aside monies as a routine each year, wellness fund, and we're inviting credible entities to apply based on a research agenda that we set that will address the challenges of the day in our country. And I believe in due course, Dr. Webster-Carr, not too long from now, we will have another function where we'll announce the first successful applicants, entities, based on the competitive process for these resources to advance the research agenda further. We have in the first instance identified 4 proposals to be supported in the areas of midlife health and wellness, a nutrition-based education intervention, a mental health intervention, and the unmet needs of cancer survivors. More, as I said earlier, will be heard on this initiative to be launched with the official handover of funds very soon. As part of the COVID-19 response, the government has developed a COVID-19 research agenda to be undertaken over the next 2 years, and this has been outlined in a coordinated national roadmap for COVID-19 research. The initiative is co-chaired by the Statistical Institute of Jamaica with the involvement of more than 70 individuals from 15 organizations. The first research product to be launched is a telephone-based survey of Jamaicans' knowledge, attitudes, and practices in relation to COVID-19 virus, which was conducted by Statin. The findings, including that those 65 years and older were perceived to be most at risk for COVID-19, is being used to guide our public education programs and community interventions. Finally, essential national health research involves the interaction of researchers, specialists, academics, policymakers, government agencies, and civil society. And this is what this conference provides the opportunity to do, which is why we endorse it, we support it, we embrace it, and we celebrate when we are able to convene. It's an unusual gathering or format this year for obvious reasons. The very reason we're discussing these various issues, the COVID and the social distancing and so on. But the technology, thank God, allows us to nevertheless achieve the objectives that we set ourselves. So it is hoped that coming out of the discussions over the next 2 days, we will be able to work together towards greater evidence-based solutions to meet our national development objectives. I want to take the opportunity to commend those who have put a lot of emphasis in coming up with these research papers, being bold, thinking out of the box, which is what would qualify you to be here and to be a participant on the agenda. The world doesn't need routine thinking in these times. We run the risk of being trapped and remaining or considering ourselves to be hopeless if we think in the traditional way. Whatever we do in this time, there's one silver lining in COVID. It offers us an opportunity to challenge the status quo, to disrupt the routine, to think out of the box, and to take on what under normal circumstances we would consider to be tabooed or out of bounds. And frankly speaking, as an academic who taught at the university for a number of years, that's exactly what research is about. Turn it upside down. Be controversial. Nothing is wrong with that. Just manage the ethical component of it. You're not harming anybody, but you're saying it doesn't have to work that way. It can work another way. And even though you may meet resistance, the fact is, that is how great ideas are born, and that is how you change the world. And the world is looking for change now as it relates to public health based on this global pandemic. Thank you. And I won't be able to stay all day, but I look forward to getting all the research papers, Dr. Webster, on a nice little technology storage. And when I have time, I'll go through them and pull from that. So I think you're going to have a good day. And for those who are online, please tune in as best as you can to be a part of the process. Thank you.
Hello? 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 Yeah, you. Hold on, and a pandemic winner. You're not wearing a mask, you're not washing your hand, and you're not keep the required 6 feet distancing from other people. And what could I really cause you? You need to stop it. That no mask, no wash, and no distance something there, nah keep. You know what keep? COVID-19. Yeah, it not gone nowhere. COVID-19, they are same way. So here what you are going to do for all of we. Wear your mask, wash or sanitize your hands pan a regular, and yeah, keep your distance, please. And thanks.
Healthcare workers are working very hard to ensure lives are saved and people recover quickly from COVID-19. But their work is becoming harder because you're not wearing your mask, washing your hands with soap and water, or using hand sanitizer, and you are not maintaining physical distance. Let's limit the need for hospital beds and ventilators. Do the right thing. Cover your nose and mouth with a mask. Practice good hand hygiene and maintain a physical distance of 6 feet between you and others. COVID-19 is not over. Protect yourself while protecting others. A message from the Ministry of Health and Wellness. COVID-19 is still here. Always wear your mask correctly while in public places, covering your nose and mouth at all times. Masks should never be worn over the head, under your chin, below your nose, or hanging from your ears. Recovery from COVID-19 can take up to 60 days or more. The mask or the ventilator? You choose. A message from the Ministry of Health and Wellness.
Hello? Hello? Yeah, you. Hold on, and a pandemic winner. You're now wearing a mask, you're now washing your hand, and you now keep the required 6 feet distancing from other people. And what could that really cause you? You need to stop it. That no mask, no wash, and no distance something there, nah keep. You know what keep? COVID-19. Yeah, it not gone nowhere. COVID-19, they are same way. So here what you are going to do for all of we. Wear your mask, wash or sanitize your hands pan a regular, and yeah, keep your distance, please. And thanks.
Morning, everyone. We're just going to take 5 minutes while we work out some technical difficulties, but we're not taking the full length of the breaks that would have been on the agenda. And so we're just asking for 5 minutes, and then we'll resume with the jingle and then start the first scientific session. Thank you. So good morning again, colleagues, and welcome back. So we're going to resume with the COVID-19 Jingle 2020 competition. And so this was a social media competition that we had. And we have the top 3 winning jingles. And so we're going to now ask our team from GIS to go ahead and play those jingles for us.
Make me come hurry up and got the people them work here. But Jesus, me nah mamas. Me nah mess up my nice match red lipstick. Girl, you idiot. Think of the consequences. Remember a public transportation you will take. What if somebody cough or sneeze? Plus, what if the person you're gonna sit beside has corona and you don't know? Girl, go put on your mask.
Don't touch your eye or your nose or your mouth as a mask with them ass out. Mask out, wait till corona pass out. Pass out, you hear a mask with them ass out. Mask out, them sexy stay in your house. Your house, hey, me love road, yes, but me top walk it.
Hold on. Yeah, right?
Yes, sir. Why am I not alright?
No, I come and see her sneeze and I come so close to me, brother.
When we make her see me and sneeze, people can't sneeze again.
And then your brother said COVID still a keep.
And what is COVID done a long time and I don't want to hear where you there. Sir, allow me, huh?
Wait. Let me show you, man. They talk about COVID done. Last thing me hear about dozen cases in a one day, brother.
Me no hear nothing like that.
You're not here, so you feel because you're not here about the case, and you're not see them in the studio about. No, man. You need to still wear your mask, sanitize your hand them, and observe social distancing.
And you know, some of my mask too, I just don't wear it more while not coming up to the use feet. But since you educate me about them some here, but as well I put your hand on me, can't afford to catch corona in a time like this. Thank you, sir.
Okay, so welcome back. And, you know, we need to really applaud the creativity of our people. It was really a good competition, and we can see that the messages are out there, and it's really just time for us to put those messages into practice and for it to become behavior. So I am Dr. Simone Spence, Director of the Health Promotion and Protection Branch in the Ministry of Health and Wellness, and I will be the first moderator in the first scientific session that we have today. As our CMO would have indicated, the first scientific session is geared towards health and wellness. And while I will be moderating the first session, just to provide additional information, we'll also be having a special presentation looking at our JAM COVID-19 application, which will be moderated by Dr. Michelle Roof. That will then be followed by a panel discussion on emerging and re-emerging infectious diseases pertinent to Latin America and the Caribbean, which will be moderated by Professor Celia Christie Samuels. And that will conclude the first scientific session for today. So back to my particular part of this session. It really is my honor and privilege to introduce our first presenter today, Dr. Sukanya Prasad, who will be presenting on perceived health concerns during COVID-19 crisis amongst Jamaicans. Dr. Prasad has a master's in public health and a medical degree and is a family practitioner and a medical officer serving both the public and private sector, spanning 25 years of dedicated service in St. Thomas. Dr. Prasad holds a Master in Public Health from Walden University, Baltimore, Maryland, and she gained her MBBS from Bangalore University in India. She is currently pursuing her PhD candidate in community health prevention, and in her spare time, she enjoys reading and giving motivational talks. She is currently the founder of the Miracle Medical Center in Morant Bay, St. Thomas, and director of Public Health Literacy USA. She is also a resident medical officer for the Ministry of Health, Golden Grove Sugar Estate, St. Thomas, Jamaica, as well as at the Diabetes Association of Jamaica, serving the parish of St. Thomas. So please, ladies and gentlemen, help me to welcome to the podium at this time Dr. Prasad, who will make her presentation.
Good morning, everyone. Thank you, Dr. Spence, for that wonderful introduction. Thank you. I want to take this opportunity to thank Ministry of Health and Wellness, the NHRC unit, the Planning Committee, for having accepted my abstract. Thank you. And given me the opportunity to present at this podium this morning. I am, as Dr. Spence said, I'm Dr. Sukanya Prasad, co-founder of Public Health Literacy. And I want to also take this privilege and opportunity to thank Dr. Webster Carr and her team for having done a great work in the public health department in Jamaica. And I'm proud to be a part of this public health team. And when I look around and I see the data around, I am really elated to be a part of this. Thank you, Dr. Carr. And I'm also proud to be a part of the parish that Dr. Carr was so proud to mention that we did a great job. Thank you for that, Dr. Carr. I want to take this time to thank and congratulate my co-authors, Ms. Lillian Smart, Dr. Narayana Prasad, and Ms. Myra Workis in helping me to put together this abstract for this morning. I want to acknowledge that we do not have any conflict of interest disclosures. Before I go to the presentation, the topic of the abstract is perceived health concerns during COVID-19 crisis amongst Jamaicans. What is perception? Perception is an awareness, it's a comprehension, is an understanding of any condition, any crisis, any medical illness. Perception of a threat to an illness, actually, whether it's accurate or not, they are the key predictors of possible health outcomes. So we believe that perception about anything is very important, whether it's a real hazard or a perceived threat. So our study is just a snapshot of the Jamaican perception at this point in time, and it's an insight to what is happening in the perception of Jamaicans during this crisis. As you all know, the COVID-19 pandemic is the defining global health crisis of our time and one of the greatest challenges that we have faced since World War II. And the risk perception of any crisis, as in anything else, is actually confronted and shaped by both the real hazards and the perceived threats. So we think it's necessary at this time that COVID-19 calls for a specific analysis to look into the perception of the health and also how it affects public health as a whole. So COVID-19, just like any other countries, has also been affecting our nation too. So what we did in this, to study the perceived health concerns, we used some methods here. We did a cross-sectional randomized online questionnaire survey during the month of August 2020. We emailed to 268 participants, and we got 34% response. That's 91 people responded. We analyzed the data that we got using the SPSS, the Statistical Package for Social Sciences. There were key indicators that came out of this methods that we used. What we found out is that amongst our respondents, about 34% of the respondents, 78% of them were females. Only 22% were male. That asks you a question, is male was not really interested, or they were not interested in participating, or they're not really taken into the perception of the COVID-19. And we also noticed more than 70% of our participants were over 35 years of age. The most, among our respondents, more than half had a bachelor's degree and higher degrees, and less than 26% had a high school education or an associate degree. It was very surprising, even though we stand out in the community, we stand out in the world, having controlled COVID-19 so well. Our country was actually divided when asked the question about how would you rate your country's preparedness to manage a crisis like COVID-19. So 52% of them believed that we were not really prepared for a crisis such as COVID-19. A question was asked about what was your biggest concern during the COVID-19 crisis. Remember, this was the month of August 2020. And the questions that were asked was about personal health, family health, social health, and economy. What stood out in this is they were concerned about the family health and the economic hardships at this time of the COVID crisis. That was their biggest concern. But continue to the question, what would they consider is their concern in their personal health? What stood out is the physical health and mental health. And I'm sure, having been a part of this team and having gone through COVID crisis in this time, we at some point in time, we all have gone through the mental stress. And having been a physician around, having worked in the public sector people, the mental health burdening crisis, have seen it firsthand. So there were major people were worried about the physical health, and there was also a biggest concern about the mental health. When it came to the health of the loved ones, the concern of it was also physical health and mental health, but social health and emotional health almost equaled off, about 14 to 15%. Physical health of the loved ones was a major crisis. As you noticed it earlier when I presented the data, I said most of our respondents were over 35 years of age. So my best guess is they might be living with their adult parents or grandparents or whatever, so they were more worried about the physical health of their loved ones and also the mental health. The question was asked, yes, we are facing the biggest challenge right now of COVID-19 crisis. Everywhere you look around is always COVID-19 crisis. But we included a questionnaire, how well are we handling, apart from the COVID-19 crisis, the other problems that we do face in the nation, physical and domestic violence. We're facing sexual abuse, the child abuse. More than half of our respondents said we are not handling these issues well at this time. As with any other study, we did have the limitations. So let me tell you some of the limitations that we had. This abstract, this study was done with a lack of large sample, especially not involving the vulnerable segment of the population. And we are unable to assess the change in the perception over time because it's just time specific to that particular time. So we're really not sure what has happened in the month of November. So that's just for that time period. And we are also descriptive in nature. We are not analytical here at all. We are just describing the problem. So to sum it all up, the perception, I said in the earlier part, perception of anything is the key for everything. It determines how the health outcomes is gonna be. So we are saying, after having seen all this data, threats, affects how we respond and how we understand our situation, whether it's real hazards or the perceived threats. So there is a major link between a complexity of how one perceives the health and how the biological health is actually connected to it. And there is an increasing burden on our mental health crisis. So if we are not sure we are heading for a major catastrophe, we are heading into it. So I was so glad when the minister was giving his keynote address and he said they are doing something about the mental health campaign and the resources are being put away, and I was really elated to hear about it. So we are thinking about it, and we are saying, okay, if there is so much mental and physical burden crisis, prevention campaigns involving the government entities, the NGOs, and would be the best thing to move forward to help and inspire and motivate people and to teach them how to handle a crisis like this. Because as CMO was saying, COVID is here to stay. The jingle said COVID is here to stay. Until we find an effective vaccine, there is always going to be this burden on the crisis, burden on mental health in our country. So we have to find an effective way to manage this. And that's my presentation for this morning. I want to acknowledge the hard work and the efforts that were placed on this abstract preparation by my co-authors. And I want to also acknowledge the great support and the love that I got in preparation from my son. Thank you. Thank you very much.
Thank you. Wow. Thank you so much, Dr. Prasad, for that presentation. And just for us to note that we will have questions and answer session after the second oral presentation. And so persons can type into the chat, which is being monitored. So especially after the first presentation, if there are any questions that you want to ask, please go ahead and type it into the chat, which is being monitored, and then they'll be read during the question and answer session. So next I have the privilege of introducing our next presenter, Ms. Vonetta Nurse, who will be presenting her abstract, The Use and Understanding of Nutrition Labels on Sugar-Sweetened Beverages, a study of consumers in Kingston and St. Andrew, Jamaica. Vonetta Nurse is a public health professional working in the areas of health promotion and advocacy. She has a Master of Public Health specializing in health education promotion and a Bachelor of Science in Food Chemistry from the University of the West Indies, Mona campus, and is currently pursuing a Master of Science in Public Health Nutrition at the University of Technology, Jamaica. She is currently the Advocacy Officer for the Global Health Advocacy Project at the Heart Foundation of Jamaica and has significant professional experience in food safety, quality management, health-related standards development, health education, promotion, and advocacy in the Caribbean. She also has professional experience in food safety and quality management in Ontario, Canada. So please help me to welcome Ms. Vonetta Nurse as she presents on her study.
Good morning, everyone. And Dr. Spence, thank you for that wonderful introduction. Let me first thank the Ministry of Health and the National Health Research Conference for accepting my abstract and allowing me the honor of presenting this morning. I'm Vonetta Nurse, as you would have heard, and I'll be presenting on the use and understanding of nutrition labels on sugar-sweetened beverages. And this is a consumer study conducted in Kingston and St. Andrew. This study was conducted in partial fulfillment of the Master of Public Health degree at the University of the West Indies, Mona. So I'd first like to start with declaring that there was no conflict of interest in relation to this study and all ethical protocols were adhered to. So for the purposes of this study, I will define a nutrition label, and that is really the sample that's on the right of your screen. The description intended to inform the consumer of nutritional properties on food. Sugar-sweetened beverages for this study relates to consume prepackaged water-based non-alcoholic products, and including but not limited to fruit drinks, soft drinks, sports drinks, vitamin water, and energy drinks. So the study was conducted against the background of an increase in overweight and obesity and diet-related non-communicable diseases in Jamaica. The Jamaica Health and Lifestyle Survey, the most recent one, would have elucidated to the fact that 54% of Jamaicans are overweight or obese. The Global Health School-Based Student Health Survey indicated a 68% increase in childhood obesity, and 78% of all deaths are caused by NCDs in Jamaica. There's also a high intake of sugar-sweetened beverages, with our teens consuming more than one per day. And of course, sugar-sweetened beverages are a leading risk factor for obesity and many non-communicable diseases. Moving on and continuing with the background to this study is that the global response to the fact that nutrition labels are considered a public health tool to address unhealthy eating habits has been mandatory nutrition labeling. However, it's voluntary in Jamaica except where there are claims. The Ministry of Health plans for the control and prevention of non-communicable diseases indicate that there is a move towards mandatory labeling. However, there are knowledge gaps in this area as it relates to who is using the label, how it is being used, and if it's being used at all, as the literature indicates that most studies have been conducted outside of the Caribbean. So while we implement our policies, there is a need to broaden and strengthen the evidence base in this area. So the objective was to perform a situational analysis to determine the use, understanding, and perception of these nutrition labels on sugar-sweetened beverages, and also socio-demographic factors that may affect the use and understanding in adult consumers. A cross-sectional mixed method study was used on a study population of adult consumers shopping at supermarkets in KSA. Data was collected between March and November 2018 on weekdays and weekends to get a broad cross-section of persons. And the inclusion criteria here was adult males and females 18 to 75 years of age who were shopping at the supermarkets, deemed to be literate and without visual impairments. So for sampling as it relates to the quantitative aspect of the study, the supermarkets were identified and to participate in the study using single-stage cluster sampling. So 44 supermarkets were identified from the Yellow Pages in 2017 and stratified based on area code into two divisions, Kingston 1 to 5 and 6 to 19. And then 5 supermarkets in each division was randomly selected for a sample size of 10 supermarkets. In terms of the consumers, previous studies conducted on consumer use of labels and using the 95% confidence interval, a sample size of 350 consumers was calculated. The interviewer, which was myself, stood at the beverage aisle and observed the flow of shoppers, and then there was a consecutive enrollment of 35 consumers at each of the supermarkets. And purposive sampling was done to try to get a representative of both genders. The data for the quantitative study was collected using interviewer-administered questionnaire, which was pre-tested before the study. The questionnaire was divided into 4 sections. So I tried to collect demographic data, data as it relates to the use of the label. Understanding was determined by a practical test where the participants were asked to look at 2 mock labels and to identify and interpret information on the label to see if they really understood what was happening there. There were also questions in terms of health behaviors, health status, and nutrition beliefs. The data was analyzed using SPSS version 2, and summary statistics were done, as well as logistic regression to identify significant predictors of nutrition label use and understanding. In terms of the qualitative study, 3 supermarkets were randomly, conveniently selected from supermarkets that weren't a part of the quantitative study, and 4 consumers from each of those supermarkets were purposely selected for the study to make up the sample size of 12 consumers for this part of the study. The qualitative data was collected using face-to-face, semi-structured, in-depth interviews, and which were recorded and lasted for anywhere between 30 to 45 minutes. Demographic data was collected, as well as insights into the use and knowledge and understanding of the label. Information was transcribed and mapped, charted and interpreted, and any conclusions were supported by quotes that were received from the participants themselves. So getting into the results, the quantitative study, in terms of the demographic characteristics, there were 144 male participants and 205 female participants with a mean age of 34.4. As you can see from the chart, most participants were single, were employed, had achieved tertiary or secondary education. Most participants had children in their household that were under the age of 18 years. Most participants didn't have nutritional qualifications, but some did follow special dietary restrictions also, although most didn't, and most had not been diagnosed with any serious chronic disease. Most participants felt that it was important to sustain healthy diets and felt that sugar-sweetened beverages were, in fact, unhealthy. Of the persons who were on the restricted or special diets, most were on a low-salt diet, followed by 14% on low-sugar diet, 13% on a low-fat diet, and others indicated low cholesterol or vegetarian diet or some other form of diet that they would have developed themselves. Of those diagnosed with non-communicable diseases or any other health condition, 8% were diagnosed with hypertension, 2.3 diabetes, and you had 5.5 other, which was really high cholesterol and asthmatic conditions or respiratory conditions. When asked what was most important when purchasing the beverage, most participants said it was nutrition value. And then this was followed by 36% saying taste, and then price and brand. So the key major findings here from the quantitative study are that 65% read the label when purchasing these beverages. However, only 24% were considered to be competent and could understand and interpret the information on the label. Almost half of the participants felt that the label was inaccurate. 71% said they changed their mind about buying this product after reading the label, and almost 2/3 thought it took too much time to read the nutrition label, and this is significant. Significant predictors of label reading is gender, employed persons, and persons with more than 3 children under 18 in the home. And these groups were 3 times more likely to read the label. Nutrition qualifications, the small amount of persons who actually had that were 2 times more likely to read the label. In terms of significant predictors of understanding the label, again, gender, females were 2 times more likely to understand, and persons below the age of 30, 3 times more likely, and those with tertiary education, 2 times more likely to understand. Notably, there was no significant relationship between understanding the label and actually using the label. The results and key findings of the qualitative study, so in terms of the demographic characteristics, they were similar to the quantitative study in terms of gender, age, education, and children in the home. The key findings, though, was that there was low label reading, consumers prioritized taste, brand, product familiarity over the nutrition information. There were positive attitudes towards the nutrition label. However, similar to the quantitative study, there were difficulties in understanding and interpreting the label. Some of the insights from the qualitative study, these are the quotes. So the major reason for purchasing would be taste. So one person said, so it would be the taste. In fact, it has a little sweetness and a little refreshing side, so that would be my go-to. And then most persons said that they didn't read the label, with one person saying, because at the time I'm purchasing, it doesn't really matter, because of the weather sometimes it's kind of hot and you just want something refreshing. And then labels were mostly clear. This was persons said so, but one person said it's a bit difficult because I don't understand the percentages and I think it's too small and confusing. And though most persons said it was clear, when they were asked to interpret the information, most people couldn't interpret the basic information on the label. So in terms of the discussion, the findings of both studies corroborate in terms of understanding the label. They were also similar to studies conducted in terms of limited understanding, demographic differences in understanding, and demographic differences in use of the label. Females, for example, may be more exposed to health education because we have greater health-seeking behavior, so which may explain why we would use the label more. Consumers with larger families use the label more, and this may be explained by cautious behaviors when you're buying for persons or loved ones, you tend to have a bit more caution in your choices. And the positive attitudes towards the nutrition label and just general awareness may be as a result of the heightened awareness of the country from existing and ongoing health campaigns. So in conclusion, respondents read the labels but don't necessarily understand them. So recommendations coming out of the study to ensure that the label delivers its intended benefits are targeted health education, cognizant of demographic factors such as gender and age. Policy change is necessary. We need mandatory nutrition labeling, but must be complemented with education as well as testing capacity, which would improve the accuracy and the confidence in the nutrition label, and further research to broaden the group of persons who are included here, including rural and even younger persons, adolescents, etc. The limitations of this study are that convenient and non-random sampling was used, and it was limited to Kingston and St. Andrew. So this precludes a generalization to the general Jamaican population. However, it does address knowledge gaps and adds to the body of evidence and new insights into nutrition labeling use in Jamaica. The mixed method provided for the use of qualitative and quantitative data, which added to the validity. Larger sample size meant a smaller margin of error, and it was conducted at the point of purchase, which allowed me to capture accurate and clear insights of the consumers at that point. I would like to close with the acknowledgement of faculty members in the Department of Community Health and Psychiatry, in particular Dr. Kenneth James and Professor Maria Jackson, without whose guidance and encouragement this study may not have been concluded. My family members, Dad Elvis Nurse, Sister Kimberly Nurse, and my life partner Miguel Julian, who contributed in ways that I cannot count, and to my beautiful, wonderful daughter Naomi Sarai, to whom this study is dedicated. Thank you very much for your attention.
Thank you so much, Ms. Nurse, for that presentation. Very interesting. Both presentations were very interesting, coming from different perspectives, one on COVID-19, the other in terms of nutrition labeling, both of which, are from looking at different perspectives of health, but both of which are interlinked in terms of looking at population health and wellness. So at this time, I'm going to open the floor for questions. And so can I ask, do we have any questions in the chat?
Yes, we do. Okay. So from C. Mill, she's asking, what is the main public health issue in Jamaica?
And that question is directed towards?
It was the first question from the very first presentation. Okay. No, it was Dr. Tufton, sorry.
So that is a little difficult to answer. And so, Dr. Webster-Carr, do you want? Right. So we'll move on to questions relevant to the presentations.
Okay, so to Dr. Prasad, was the sample taken only from persons living in St. Thomas?
Thank you for that question. No, the sample size was not done from St. Thomas alone. It was done in the Jamaica entire population.
Okay, thank you.
Yes.
That's it.
Dr. Prasad, this question is also for you. Were there any studies done on the mental health situation among frontline/direct healthcare workers responders for COVID-19 locally and internationally? Also, what are best practices at places in our local context to support the mental health of COVID-19 frontline responders?
Okay, thank you for that question. In our study, what we did is a generalized questionnaire that we prepared. It's asking about physical health, family health, mental health. I am not sure if any mental health studies have been done in Jamaica at this time, but what we focused is asking people what is their priority at this specific time. So we had, is it physical health, is there family health, is there mental health? But if you ask me to dissect what in the mental health, no, that question was not asked. It was just basically basic questions were asked for this. So I'm not sure about any other studies being done in Jamaica at this time. And I also would love to know if there are any studies being done now, you know.
Okay, so there doesn't seem to be any additional questions from the chat. And so at this point in time, are there any questions from persons in the room? Just checking once, twice, 3 times. All right, so that therefore would conclude this first segment in terms of the health and wellness part of the scientific session number 1. And so I really, again, would like to thank both Dr. Prasad as well as Ms. Nurse for their presentations. Very interesting information indeed, and certainly information that we can build on so that we can look at the policy level at possible interventions to support and continue to support the health of our population. Thank you very much, ladies and gentlemen here, as well as those who have joined us virtually. It really has been my distinct pleasure to host this first scientific session, although a little different feeling. You know, the vibe in the room and so on is not as nice as when we had it at Jamaica Conference Center and the buzz. And I'm sure that is also contributing to the lack of questions, but you know, we are learning to adapt. Oh, I should also indicate that there are posters online to be viewed, and so persons can also view those posters online as well as even in between the oral presentations. I think we are going to go to break at this point in time, and then after break we'll resume with Dr. Michelle Roof, who will be looking at the JAM COVID-19 application with the person who created the application for the Ministry of Health and Wellness Jamaica. So thank you again, ladies and gentlemen, and we look forward to your continued engagement throughout the rest of today as well as into tomorrow. Thank you again.
Good morning, everybody. Welcome back to our conference. This session is a special presentation. I'm your moderator, Michelle Roof, Senior Medical Officer, Ministry of Health and Wellness, responsible for health informatics. A special presentation on JAM COVID-19 application will be made by Mr. Dushyant Savadia. He is viewed as an entrepreneur with global reach, a humanitarian, and among others, a noted public speaker. He is a native of India and currently lives in Jamaica and was instrumental in making our country the headquarters of the Amber Group with offices in 23 countries. He is an international program director of the Art of Living Foundation, one of the largest global humanitarian NGOs that focus on improving the quality of life by focusing on developing a stress-free, violence-free global society. He has traveled extensively to over 50 countries across the globe and has personally led stress management workshops to people from different walks of life, from farmers to corporate executives, inner city communities to heads of state, as well as youths to prison inmates to reduce stress, crime, and violence. Good people, let us welcome Dushyant.
Very, very good morning to everybody across Jamaica, in the region, and anybody who's watching this telecast. Very good morning again. My name is Dushyant Savadia. I'm the founder and CEO of the Amber Group. Thank you for a very kind introduction, Dr. Roof. It was a little exaggerated, but I'll take it. Amber Group is a global technology conglomerate. We operate in about 23 countries right across the world, headquartered in Jamaica, and very proudly a Jamaican company. I've lived here myself for nearly 8 years, came here for a humanitarian mission, and made this home. And we all know Jamaica has this innate ability to make people so welcomed and so much at home that you never want to leave again. So that's one of me. I didn't fall off a boat and land here, but I chose to make this home because of where this country is going, who we are as a society, and of course my innate passion to serve in whatever way I can. Amber Group has several business lines: Amber Connect, fleet management, vehicle tracking. We have Amber Innovations, which is a software development wing of the Amber Group. We have over 200 software engineers in-house. We have Amber Pay, a payment system that is rolled out in many countries around the world. We also have Amber Aviation, Amber Fuels, and so many more in the pipe. But today, we're going to talk about the COVID-19 application that we designed and developed, and how this pandemic management solution in the last 7-8 months from its inception has blown into a massive enterprise solution managing the end-to-end pandemic management for a country. And I'm very proud to even share with you all today is that what we designed, developed through the help of the medical fraternity, through the help of technology, and all of these brilliant minds, and many ministers who worked with me directly, including the Prime Minister, all of us came together to think through and build an application to first bring home our 25,000 stranded citizens who were abroad, residents who were abroad and couldn't come home, bringing them in a safe manner so that once they arrive, the risk is known and that risk is contained, and then opening up our economy, which is opening up our borders for business, and then also within the country, how do we manage the symptoms, how do we manage the testing, how do we become a single source of truth for citizens to know, to reach out to understand information, understand the statistics, and so on. And over the last 7 months, the solution became a massive platform, so much so that it became a regional pandemic management software, now actually being utilized and being launched by many other countries in the region from Jamaica. So we've learned, we have adapted, we have put in so much of technology that this became a software hub or a requirement for all other countries too, so much so that we came to a point where we are now launching in BVI, in Turk and Caicos is launched, Grenada, Antigua, St. Lucia. There's so many countries coming on board with a solution that has been adapted, that has been consumed, that has been saving lives and keeping our economy running. So I'm going to give you a presentation around the pandemic management solution, and I'm going to go back to our slide to just walk you through the different modules that are existing. Again, this is not an exhaustive list. On a weekly basis, there are just so many new features and so many new things being plugged into the system, literally connecting 5 ministries of the government together to sync together, to understand the nuances and understand how to manage the entire pandemic for this country. And touch wood, so far we've been extremely blessed with over 200,000 people who have arrived from abroad and from high-risk countries such as United States and so on. We're still at around 4,500 active devices. So I would want to take a pause and give my absolute gratitude and thank you to all the nurses, to all the doctors behind the scenes, everybody at the airports putting their lives at risk for us and ensuring that the technology does what it's supposed to do, but the manpower with the technology is what has kept us all safe. So please join me for just a moment to say thank you to all our front runners who have kept us safe and kept us away from harm and kept our economy growing and going. So I'm going to start off with my presentation. Next slide, please. That's right, it's not reaching. Yeah. So, purpose of this pandemic management solution was simply to help countries to take control of their COVID-19 health case management systems, initiate immigrations and ports of entry screening, and secure travelers tracking and tracing. If I move to the next slide, please. So the first thing that you will see, if you actually haven't downloaded the Jam COVID app, I would suggest you do so. It's a very simple to use, beautiful application that gives you such a wealth of information and where we are as a country. So the first thing that you would see, that there is a beautiful analytics dashboard. It's got an Android app, an iOS app, and it's got a website also where you can see a lot of analytics and so on. And as you would have seen from the media all across in the last 7 months, this platform has been very highly commended, the way it has functioned and the way people could use it and gain entry into the country, and how we manage the pandemic on top of it. So it's a very simple, comprehensive, interactive mobile app and website that has allowed the governments to centrally develop, manage, and disseminate crucial information related to the COVID-19 pandemic. The solution includes provisions to enable travel authorization, airport screening, tracking and tracing, and support quarantine measures. The public has real-time access to interact with this information. The digital case management, when I say end-to-end pandemic management solution, it actually became the world's only end-to-end pandemic management solution with a single digital folder for every single person arriving into the country till they depart, or even if they are in the country under a 14-day quarantine period. So, and very proudly so, Jamaica became the only first country in the world to launch a travel authorization system which is designed around the health assessment pre-arrival. So there are 6 of these massive big modules. The first module is the health pre-screening, immigration and travel authorization. Now what this does, literally, can you imagine if we did not know as a country who's coming, from where, what are their existing medical conditions, or what are their existing symptoms, or we do not have the ability to get the negative test result verified in advance. Where are they going to stay? How long are they going to stay here for? Without all of this crucial information, the operations as a country would have been very difficult. So the health pre-screening and the immigration and travel authorization system became the first digital travel health organization authorization system. That means you go online if you want to come into the country, resident or tourist, you need to go, apply, give all your information, load your negative test certificate if you're a tourist and coming from a high-risk location, and again coming into the country with the risk of the spread here. And then once you've done the application, provided your health screening, it's verified, and it gives a travel authorization certificate, without which no airline will board. So imagine this, if you come to the airport and you've not gotten your travel authorization certificate in advance, the airline will not board you. Jamaica became the first in the world also to integrate that into thematics, where all the airlines were mandatorily asked to ask for this travel authorization certificate for Jamaica before any passenger can board, because unless we don't have that information, that person coming in without us knowing their health risks, it exposes the country into a greater risk. So we have to be very proud as a country to launch so much of technology which aided the local operations of the health departments to function much more smoothly. So that's the travel authorization certificate. You need to get it done first. You get approved, and only on approval you get a travel authorization certificate, which the airline will mandatorily have to see, and it has to match your passport number, your first name, last name, and your date of birth. And if any of these things mismatch, you can't board the flight, because it's almost like an e-visa, but it's a health e-visa. So that's what. And then this is now fully integrated into the customs and immigration backend here. That means, if you could imagine, normally when you come, you write that C5 form, the landing card on arrival, and if it is not available in the plane, you have to stand somewhere in the airport, write it down to get immigration done. So the immigration and customs is now fully integrated into the JAM COVID system. That means you no longer have to do a manual paper-written C5 form on arrival into the country. You do your travel authorization certificate, and your immigration is also done as a part of it. That means once you come to the immigration desk, they simply scan your passport, all your information is uploaded. So it's a digitization that none of the countries in this region have ever done or seen before. And we became the first to launch that as a nation. Second part of it, once the person arrives at the airport, what happens? The second module is around the airport health screening module, right? Maybe I'll just go through each of these one by one so you can see how the dashboards look like. So this is the health pre-screening, immigration and travel authorization. As you can see, there is a St. Lucia website. This is coming live shortly because St. Lucia has also adapted this technology for their country. Apart from St. Lucia, there are 5 more nations in the region who are also doing the same now through Amber Group. Next slide, please. So we're going to module 2. Then there's this airport health screening. What does this do? Once the persons arrive at the airport, the nurses have a tablet where they are able to load up the passenger information using the passport number, reference number, or a QR code, which is also on the travel authorization certificate, and then load that passenger information. And then also at the same time, once the passenger information is up, the nurses are able to do their health assessment in the tablet itself by putting their physical temperature, observations, and then based on the health risk at the airport and the purpose of your visit and where you're staying, they issue you a quarantine order that you as a passenger sign on the tablet itself, and a copy of that quarantine order is sent to you by email. So that's another layer of digitization. Now I want you to start thinking how this journey of a person is captured one by one through a digital process from pre-arrival and then on arrival. Then you have in-country analytics, which is the third module, which allows you to actually see the current statistics, how many male, how many female, what age group got COVID-19, got recovered, died. There's so much of data analytics that is now present on the mobile app and on the website both, and you will be amazed, including projections, that if based on the current trend of how many cases we are getting on a daily basis, if it doubled by 6 times, 10 times, or twice, what will Jamaica reach to if that happens? So there's so much of analytics, which on a daily basis, I wake up first and see what is the status, how many active cases are there, and what's happening by parish. All of that statistics is now visible and available through the mobile app and the website. Then you have the in-country analytics backend. Now bear in mind, there is a whole backend module built, which is massive, used by the Ministry of Health, by PICA, and so many agencies that interact into a single backend. It has user management and parish management and country statistics. There is a news management as well with a lot of BI dashboards, a business intelligence dashboards built on the backend for Ministry of Health to see how many applications came from which countries, how many people are staying in clusters across every parish so they can operationalize their workforce better within the country. So there are a lot of analytics built in to give the right intelligence so the operations can function better. Module 5 is self-reporting. What happens if you fall sick? You are a resident or a tourist and you're in the country and you start seeing some symptoms. So rather than clogging at the hospitals, you can actually go online on the website or on the app, register yourself, give your details, put your name and address and phone numbers, etc. Plus on top of that, you register your symptoms, you register your temperature, and we also begin the contact tracing process right there. That means if you're symptomatic, you have the ability to put, if you've come in contact with anybody who has traveled within the last 14 days, what is their name and phone number and email, and if you have been in touch since being symptomatic with others in your family or friends in the last few days since you became symptomatic. So all of that information that is collated helps the Ministry of Health to then go out, contact tracing, and get in touch with these persons, also to get tested because they've been in contact with somebody locally. So there's a lot of contact tracing is managed in the back end, but on top of that, it's also an appointment booking engine. That means if you're symptomatic, you must get tested. So if you need to get tested, that means that immediately you can go into the app, book an appointment, choose the closest center where testing is possible, and then choose a time slot, choose a date, and then you show up for your appointment. And each of these testing sites also have their back-end portal. They know what date, what time, who's going to come, and they check you in as soon as you arrive. So that's another huge module built in the back-end. Then you also have the quarantine management module, which also allows persons who are coming in from abroad and whether you're a resident or a tourist who is not going to a resilience corridor would actually download the app. On a daily basis, you do a video health check-in. That means on a daily basis, you will be prompted at a certain time of the day randomly to open the app and give your temperature, give your symptoms, and then do a video health check-in. So that all information of your 14 days of log on a daily basis is what allows the Ministry of Health to release you from quarantine digitally at the end of 14 days. However, within that 14 days, if there is a temperature spike or you report a symptom, it would automatically alert the Ministry of Health to take special attention to that particular case by also extending the number of days that you need to quarantine as well. So there is a lot of machine learning, artificial intelligence, a lot of algorithms built that allow so much of automation in the backend. And yes, there is a tracking feature built into it, but we are not really collecting your location. And there's a lot of myth around, oh, I don't want to give my location to anybody, I don't want anybody to track. But the technology has evolved so much that we do not really need your location at all times unless you become a person of interest. So the way the system is designed is that when you go home the first time and you do your first check-in, we register where you live because you've already given your address and so on in the application. And we are only checking every 30 minutes whether the phone is in the same location or not, but not collecting the information out of your phone. That means that only if you leave your house, only then it will send off an alert with your current location because you're not in your location. And you're putting the whole nation at risk because of you deciding to leave the house and breaching your quarantine order. And hence, it is very important that everybody also understands with this forum that it's not really, we are tracking you all the time, which room you are in and where you're going. It's only checking if you're there or not. Only if you're not there and you're in breach, it starts sending information to the servers and it goes to the command center of the police force, to the JCF, and they see in real time who's leaving their home. So this is how the system is designed. We also have a quarantine management backend. It's just there is no real data in anything you're seeing. This is just a template example. Imagine if you've got 200,000 people and Ministry of Health wants to find one person of interest. It's very easy for them to find where they go on this quarantine management backend, type in the reference number, passport number, name of the person, and it shows them on the map where each of these persons are located. And they also know when tourists come in, when residents come in, who is going into a more vulnerable area and how many people coming from abroad who carry some form of a risk are going into these vulnerable areas, and be a little more mindful around the operations and deployment of resources around the clusters where the intensity of number of people who have come from abroad are more, because that is where the risk is. And also there is the internal risk of the spread too, which is also handled in a different way in the system. And then there are wearable tracking solutions also, which has been deployed in many regions across the region as well. A lot of the countries have done that for high-risk persons who come from abroad, from high-risk locations. They either wear this watch, so it does not need a phone really anymore. The watch itself or that ID card with that little bracelet that you can see, these are two wearable tracking solutions which are deployed across in the region now. So this watch, you wear it once, it checks your temperature, it checks your heart rate, and it sends that information to the health ministries in the region for ensuring that while you're in quarantine, that your health is okay. And if any of these devices send a temperature which is very high, then immediately the Ministry of Health are able to proactively work with that person to get them tested and assist them with their isolation also, and protect the nation at the same time. Plus, these wearables are trackers. That means it is sending information in real time. Again, only if you leave the location. The geofencing is done on where you live. So if you leave that particular location, it will send off an alert straight away. If not, then absolutely not. And again, based on how the data privacy is managed, after 14 days, all your video check-ins, if there is any tracking data collected, everything is deleted from the system automatically. So there's a lot of security, there is a lot of thought process gone behind in protecting the data, protecting citizens, and protecting the country at the same time. So the data storage, the access permissions, how the user management is defined. There is a proper audit trail in the application of who has gone in and done what also. It's a beautifully designed system, and that is why we are not even surprised that this became an envy of the entire region, that the entire region has now adapted this technology, and hopefully in the near future, all these regional countries who have adapted the same solution, we can integrate at some level with all of them, which can create a free flow bubble movement, because we know the health records of each of these persons moving around within these countries, because we have a single data system across the entire region. That's pretty much us. We are Amber Group, and I would also like to thank the entire development team. As you know, Amber Group designed, developed, and contributed this massive software at no cost to the government of Jamaica. This was our social responsibility as a company based in Jamaica, situated in Jamaica, and it's almost said when your fire is at when your home is on fire, it is your personal duty to ensure you do everything you can to put it out. So as a company, we're very ambitious in serving. We're very ambitious to do good. And out of this very innate nature of our business to want to do good, we continue to innovate. We continue to build software for businesses, for large corporates, from governments to every single sector of the society. We want to touch, we want to serve, and we want to be useful to the society in every way we can. With these words, I would like to thank you all for listening in, tuning in, and again, my gratitude to the Ministry of Health for a fantastic management of this pandemic in this country. Without you all, we would not be where we are. Thank you so much.
Thank you so much. Thank you so much, Deshant, for such a beautiful presentation. I must say, when I was reading your profile, I was thinking to myself, the presentation to follow doesn't really get seen in this profile, because what we saw was somebody who was an entrepreneur, humanitarian, and what we saw coming out of the presentation was somebody with special gifts and a vision for innovations at the enterprise level, and that's certainly what you saw presented just now. I want to also echo his commendation to the staff who worked so brilliantly. The first application was the airport screening tool, both at NMIA and SIA. And I must say I was surprised that some of those nurses are, my age, so the grays are real, and probably a little bit older, but they adopted and adapted to the technology very, very quickly at both airports, and that was very commendable. So you truly heard about an ecosystem, cross-platform, crossing a number of sectors, and that's what has made this truly a beautiful application. So I will now turn over to those who are assisting us with fielding the questions that you may have.
Okay, so Mr. Deshant, for the watch, is it possible to quickly figure out if this watch is removed before the time of quarantine, and also, is the watch waterproof? Is it possible to quickly figure out if this watch is removed before the quarantine time expires, and also is this watch waterproof?
Okay, so if you remove the watch, it will send off a device tamper alert straight away. Immediately, instantly. If you cut the watch, if you remove the watch, it will send off a device tamper alert instantly.
Okay, thank you. And can you say how effective this system has been in identifying persons in breach of the quarantine order?
I would leave that for the government of Jamaica to disclose those information.
Okay, thank you. That's all.
Well,
Sir.
So I would just make some additional comments on those two queries. The Jam COVID app does allow us to see those persons who have exited their home location. There is an alert, and we can also see them on a map. So yes, we can. The thing would then be the enforcement of the disaster risk management orders, having seen that this person has exited their home. There was a second point, eh? Or the wearable.
Waterproof. Is the watch waterproof?
So I would just like to say, I tested a wearable. It wasn't from Amber, but some other country, over a weekend a few weeks ago, Friday till Sunday. Similar to the one he showed, the black one that looks like a regular watch on the screen. And so they were able to monitor my movements and see that I left my home, which was the office. And also they were able to pull my temperature readings every interval and have that on the monitor. So I wasn't required to do a single thing. And that's the beauty, similar with his products, of these. You don't have to have a temperature, a thermometer, and you don't have to remember to take your temperature. It pulls this information at intervals. Of course, there are issues about tracking people, knowing where you are, and how much tracking should be done, and what happens with that tracking data. Because really an app should only be able to say you have exited your location, but it shouldn't be following you. But then there's another bit of argument that says it should follow you to know where you went. Because if you're exposing other people to COVID-19, we need to know where you went, because you might not tell us the truth when we're doing the contact tracing with you. So the technology is beautiful, but one thing that we're always aware of, and he's mentioned it very nicely in the presentation, is a whole right of privacy versus right to protect the rest of the population in the case of a pandemic, such as this one, and other parameters in the software and the technology itself to ensure data privacy is maintained. Are there any other questions?
Yes.
Please carry on.
Okay, so you had answered the questions about privacy, and okay, so someone's asking, how is passenger confidentiality maintained if the information is removed from the app once the passenger leaves the island? Mr. Dushant. From the app once the passenger leaves the island.
Once the 14 days period is over, as soon as the 14 days period is over, every single data that is linked to your video check-ins and it's linked to your tracking, if there is any collected, if you breach, then of course there is data, all this information is automatically deleted from the system. So the system is designed intelligently enough to remove all the data that is no longer required to manage the process going forward. So after 14 days, any of your health data, any of your tracking data, video data and tracking data is removed from the system automatically. So there is no manual intervention there at all. As soon as 14 days is over, person is released from quarantine, everything is deleted automatically.
Thank you. Thank you.
Thank you. Have any more questions? Okay, thank you.
Okay, so that brings us to the end of our special presentation session on the JAM COVID-19 app. Thank you for your attention and participation, and have a good day.
Hello? 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 Yeah, you. Hold on, and a pandemic winner. You're not wearing a mask, you're not washing your hand, and you're not keep the required 6 feet distancing from other people. And what could I really cause you? You need to stop it. That no mask, no wash, and no distance something there, nah keep. You know what keep? COVID-19. Yeah. It not gone nowhere. COVID-19, they are same way. So here what you are going to do for all of we. Wear your mask, wash or sanitize your hands pan a regular, and yeah, keep your distance, please. And thanks.
Healthcare workers are working very hard to ensure lives are saved and people recover quickly from COVID-19. But their work is becoming harder because you're not wearing your mask, washing your hands with soap and water, or using hand sanitizer, and you are not maintaining physical distance. Let's limit the need for hospital beds and ventilators. Do the right thing. Cover your nose and mouth with a mask. Practice good hand hygiene and maintain a physical distance of 6 feet between you and others. COVID-19 is not over. Protect yourself while protecting others. A message from the Ministry of Health and Wellness. COVID-19 is still here. Always wear your mask correctly while in public places, covering your nose and mouth at all times. Masks should never be worn over the head, under your chin, below your nose, or hanging from your ears. Recovery from COVID-19 can take up to 60 days or more. The mask or the ventilator? You choose. A message from the Ministry of Health and Wellness.
Good morning.
Hi, good morning. This is Laverne. How are you, Miss Samuel? This is Laverne from Islands now.
Yes, I can't speak to you now. I'm in the middle of a conference, a teleconference. Sorry, ma'am. Good morning. Shall we start? Have I got the go ahead to start this next session?
Good morning, everyone.
Good morning. Good morning. I am Celia Christie. I'm Professor of Pediatrics, Infectious Diseases, Epidemiology, and Public Health here in Jamaica at the University of the West Indies and its University Hospital. The University of the West Indies heartily congratulates Health Minister Dr. Tufton, Dr. Bissessor Mackenzie, Dr. Webster Carr, and their team from the Ministry of Health and Wellness in their stellar response to the COVID-19 epidemic and the staging of this 11th annual National Research Conference. The UWI participates with the Ministry of Health and Wellness in diverse collaborative initiatives related to the COVID-19 response, and this includes educational conferences, clinical care, and research. And you would have heard some of the research that is going on here at this conference. So now it is my pleasure to chair this special session, and it is entitled Re-Emerging and Emerging Infectious Diseases in Latin America and the Caribbean. And we have a very distinguished panel of local, regional, and international experts. Doctors Karen Webster-Carr, Stephanie Fletcher-Larty, Kimberly Brower, and Wilmore Webley, and they will be with us for the next hour or so. So in the past 5 years, Latin America and the Caribbean region has faced the introduction of chikungunya, Zika, and SARS-CoV-2 viruses, as well as the resurgence of dengue fever. So now we invite each speaker to share theirs or their organization's experience with these and the other emerging and re-emerging diseases. We also wish the speakers to explore any other potential threats which may be on the horizon based on their particular area of expertise. We're asking the audience to pose your questions in the chat box, and they will be addressed after all of the talks. So we will begin today's program with a special presentation on re-emerging and emerging infectious diseases pertinent to Latin America and the Caribbean. And Dr. Kimberly Brower will start the discussion. Professor Brower is a professor of infectious disease and epidemiology at the Herbert Wertheim School of Public Health and Human Longevity Science at the University of California in San Diego. Dr. Brower also serves as the vice chair for public health education, and she co-directs the global health track of the University of California, San Diego campus for the joint doctoral program in public health. She earned her PhD in molecular epidemiology from Johns Hopkins University of Hygiene and Public Health. And she was also awarded a Fulbright Fellowship where she studied in Zimbabwe. So we're going to ask her now to set the stage for us as she speaks to us on this particular topic from her particular point of view. Professor Brower, welcome. please unmute your mic.
Okay, do you hear me now? Can you hear me?
Yes, I do, and I'm sure the rest do as well. Thank you.
Excellent, and can you see my slides as well? Perfect.
Yes, I can.
Okay, hello Jamaica. Thank you for your kind introduction, Professor Samuels. And thank you also to Nicole Martin-Chen and all involved in inviting me to this esteemed event. The urgency and importance of this conference is evident now more than ever. I was asked to share with you factors driving the emergence and reemergence of infectious disease threats, especially those that may be overshadowed by COVID-19. However, I know that this session has a great lineup of speakers, including Dr. Fletcher Larchey, who will present on regional emerging infection issues, and Dr. Webster Kerr, who will detail national emerging infection concerns. So given that I'm an epidemiologist and we're interested in discovering both drivers of disease as well as strategies to address emerging diseases, I'm going to speak on both of these topics. As you know, emerging infections involve outbreaks of previously unknown diseases. But we should be equally concerned with reemergence of known diseases that may be rapidly increasing in incidence or geographic range for a variety of reasons. Emerging infections have been reported throughout the world, in some places more than others, but no matter where a disease emerges, it's everyone's concern since the world is so interconnected. This leads me to the first driver of emerging infections, mobility and migration. The Zika virus epidemic in the Americas is a clear example of how human mobility presents the perfect conditions for rapid disease spread. Brazil hosted several major sporting events in 2014, including the World Cup and VA World Sprint Championships, which are widely thought to have seeded the epidemic. This, along with favorable climate and weather conditions that led to increases in Aedes aegypti populations in much of the Americas, created the perfect conditions for emergence of Zika. Human climate change and associated flooding has also led to leptospirosis being recognized as an emerging global public health problem. And climate change will continue to be a major driver of emerging infections, sometimes in combination with other factors, such as human susceptibility. For instance, weather has played a role in extending the distribution of Anopheles mosquitoes to higher elevations in Kenya, thus exposing susceptible highland populations more frequently to malaria. Human susceptibility to infectious diseases has been further exacerbated by the HIV pandemic, new immune
Professor Brower, we missed you hearing.
Yes, I see. I disappeared right
yes, so we're
during a grim part of the talk.
Yes, we're halfway through this slide. I think we stopped hearing you when you got to human susceptibility. Would you mind?
Excellent. I'm back online and I will continue. As I mentioned, human susceptibility to infectious diseases has been further exacerbated by the HIV pandemic, new immunosuppressive drugs focused on cancer and other concerns. And sadly, in the US, this also includes an anti-vaccine movement. Other key drivers include rising antimicrobial resistance, poverty and social inequities, urbanization and overpopulation, and Aedes mosquitoes in particular thrive in urban environments, and at times a lack of political will or discrimination of most affected populations. So all of these issues paint a fairly grim view of the future of humans and emerging infections. Throughout human history, if you look at infectious diseases, they've plagued mankind all the way from the bubonic plague to more recently the 1918 influenza epidemic, and now, unfortunately, COVID-19. It may seem like we're destined to repeat encounters with new infections, leading to a lot of human suffering. However, unlike in centuries past, we now have the knowledge and tools to make important steps to respond to emerging infections, even when a vaccine or adequate treatment isn't yet available. With big data becoming ever more readily available, disease surveillance is becoming faster and more accessible, giving us more time to prepare for coming plagues and decide where to focus resources. There are multiple global sites providing daily and weekly alerts on new disease threats, such as ProMed. However, surveillance can be particularly affected at the local level and isn't limited to counting just human cases. For instance, last year, Dr. Zach Madewell, a student of mine, published work comparing human and vector surveillance strategies for Zika, including using Aedes aegypti traps and monitoring emergency department data, thus finding that both strategies had their merits. Increasingly, we also have access to instantaneous data, such as through syndromic surveillance of Twitter data and pharmacy data that can be used to identify unusual events, such as when antidiarrheal medications sold out at pharmacies in the US state of Wisconsin, heralding a Cryptosporidium parvum outbreak. Beyond preparing us, surveillance data is also essential for attracting attention and much needed funding to neglected emerging infections. For instance, here in San Diego, we are testing non-ischemic heart disease patients for Chagas disease, identifying 5% infection rate thus far in Latinx migrants, with the hope of drawing much needed attention to this issue. Through epidemiologic methods and increased access to data, we can acquire knowledge and make smarter decisions when reacting to emerging infections. For example, during the 2009 H1N1 pandemic, UC San Diego debated closing the student dormitories to stem transmission. Before making this decision, however, we conducted a study with student health to map, track, and genotype cases on campus. We hypothesized we'd see genetic clustering in dormitories, which would be hotspots for transmission. But to our surprise, however, most cases were in students living off campus. And even those within dorms lacked clustering of genetic data, suggesting that the dormitories themselves were not major transmission sites. So these findings informed a decision not to close the campus. So not only does understanding transmission help you to make smarter decisions, it also gives you the strategies to act, even if you don't yet have treatment or vaccines. And this has been made all the more evident by the COVID-19 epidemic. While we can determine where infections occur and how to stem transmission, winning over public sentiment is key to success. As seen in recent months, the influence of those refusing to wear masks can have a huge impact. So balancing negative perceptions with positive messages by musicians, artists, government leaders, sports stars, and others can make wearing masks, emptying mosquito breeding containers, or using condoms the social norm. Finally, with each pandemic, humankind has gained tremendous amount of knowledge about prevention and treatment of disease. The cholera pandemics of the past spawned a sanitation revolution that tremendously improved health and prevented many diseases beyond cholera. Vaccine research for the HIV pandemic, while not yet yielding a successful HIV vaccine, has given us new vaccine strategies that have made it possible to develop an effective COVID-19 vaccine at warp speed. So while a year ago, most people didn't know what an epidemiologist did, and public health departments, at least in the US, were on a shoestring budget, hopefully the great transformation from the current pandemic will be a lasting investment in and appreciation of the value of public health, so that we are better prepared to face the emerging infection challenges of the future. Thank you very much.
Thank you very, very much, Professor. You have shared 5 big issues that we need to overcome to address these emerging infectious diseases. First, you told us and reminded us of the various pathogens that are affecting the world, and some of them are definitely here in the Latin America and Caribbean region. And then you pointed out for us the drivers of emerging and re-emerging infectious diseases. You gave us some of the tools, the knowledge and tools to respond to these EIDs, paying attention to surveillance and what we should finance. And here in Jamaica, it's very important to us as it relates to winning over public influences. And here we use our community leaders to help us to drive change, especially our singers and our musicians and our artists. And then again, you really showed us a little bit about what we can do for the future to go forwards. So we look forward to hearing more from you during the question and answer period as we move on to the next speaker. Thank you so very much.
Thank you.
Yes. And our next speaker is Dr. Stephanie Fletcher-Larty. She is a public health and biopreparedness epidemiologist with over 23 years of public health experience. Her career spans the areas of research and frontline infectious disease management, environmental health, and emergency response. She has worked here in Jamaica, and she also has worked in Australia, where for over 5 years, she was a biopreparedness epidemiologist at the New South Wales Ministry of Health in Australia. She has had numerous awards and is currently a consultant with the Caribbean Public Health Agency, and she coordinates the work of health information, communicable diseases, and the emergency response team from a regional perspective. And so we now ask Dr. Fletcher-Larty to share the perspective of CARFA.
Thank you very much, Professor Christy Samuels. Please allow me to just share my screen. I want to thank the Ministry of Health and Wellness for the invitation to present on behalf of the Caribbean Public Health Agency. Today, I'm going to present a brief overview of the Latin American and Caribbean region, and we are going to look briefly at new and re-emerging diseases of relevance to the region. The Latin American and the Caribbean countries, they vary tremendously in terms of their level of development and their epidemiological profiles. Yet they face a series of public health threats that are quite common across each region in this season. The persistence of diseases such as dengue, tuberculosis, and malaria, and the emergence of new diseases and increasing cases of antimicrobial resistance emphasize the need for flexible and responsive public health systems. The Caribbean countries consist mainly of small island developing states, which increases the region's vulnerability to public health threats. This is due to various factors such as the variability in their capacity to respond to public health threats, the geographical vulnerabilities and to disasters such as hurricanes and earthquakes, and of course, limited resources for the health sector response. In addition, porous borders and the interconnectedness of our countries through travel and trade further increases the risk from public health threats. The Caribbean Public Health Agency, as an expression of the regional cooperation in health, has a core mandate to strengthen core national health system surveillance. And one of its key functions is to support its member states to strengthen their capacity to respond to certain public health threats, such as outbreaks of communicable diseases, and to maintain high levels of coverage of vaccine preventable diseases. Over the past decade, the region has been negatively impacted by repeated outbreaks of new, emerging, and re-emerging infectious diseases that has tested the region's health security capacity to respond. Now, the chart that I'm about to show you contains data that has been captured through the Caribbean Public Health Agency's integrated surveillance systems over the last 10 years. Now, these diseases recorded here include outbreaks of norovirus, cholera, malaria, chikungunya, Zika, and influenza H1N1, and more recently, the novel coronavirus disease. Prior to the COVID-19 pandemic, the region was challenged by the emergence of two mosquito-borne diseases, chikungunya and Zika, and earlier with the influenza H1N1 pandemic strain. Now, this second figure here shows mosquito-borne disease outbreaks of dengue in 2013, chikungunya in 2014, coinciding with the introduction of Zika in 2015. We see also the lower incidence of dengue and CHIKV. And subsequently, in 2016, we had an outbreak of Zika. Now, this last graph here shows the distribution of the influenza and other respiratory viruses that are under surveillance. And this data is for 2019. And this represents information from our medical microbiology lab. Now, influenza A H1N1, which is the pandemic strain, which is represented in this chart by the orange bars, was introduced initially in 2009. 10 years later, we see that this is still circulating with a cyclical pattern that coincides with peaks earlier in the year in February and March, and later in November and October. This coincides with the Caribbean's tourist season. Now, one would ask, will a similar pattern be observed with COVID-19 going forward if a long-term solution is not found? Now, moving on to mosquito-borne and vector-borne diseases. Vector-borne diseases such as CHIKV and Zika, they require certain elements which must coexist for the occurrence of diseases. There must be people who are susceptible to the disease. There must be the vector present, and of course, the pathogen. Most countries in Latin America and the Caribbean have abundance of susceptible people, and the mosquito vectors are readily available. Now, gaps in our surveillance and the need for a separate surveillance system to monitor the congenital defects associated with Zika virus are some of the critical issues that must be monitored in order to preserve our gains going forward. The Caribbean Public Health Agency works with its member states to enable them to prevent, control, and respond to the debilitating effects of mosquito-borne diseases through our traditional and innovative integrated vector management strategies. The World Health Organization region of the Americas was initially declared free of measles in September 2016. But Brazil and Venezuela eventually lost their measles-free status due to outbreaks occurring in 2018 and 2019. Now, in 2019, 14 Latin American countries reported confirmed cases of measles. These sustained outbreaks of measles in the region highlights the ever-present danger that underscores that a measles-free status is hard-won but easily lost. The absence of indigenous measles in the Caribbean for the past 18 or so years has been a result of the collaborative efforts between the national health authorities and the Pan American Health Organization in maintaining and validating coverage for the measles vaccines and in ensuring that detailed action plans for improved coverage are in place. However, when we compare the first epidemiological weeks in 2020 with epi weeks 12 to 45, the Pan American Health Organization reports that there was an 88% reduction in the reported cases of measles and rubella, which highlights the impact of the COVID-19 pandemic in the notification of our vaccine preventable diseases in the region of the Americas. Our public health staff must continue to maintain the vaccination coverage in order to preserve the gains that we have so seriously gained over the years. Now, to echo the words of Henrietta Forey, Executive Director of UNICEF, the measles virus will always find unvaccinated children. If we are serious about averting the spread of this dangerous but preventable disease, we need to vaccinate every child in rich and poor countries alike. Now, to move on to speak a little bit more about COVID-19, this has become the region of the Americas has become the epicenter of the COVID-19 pandemic. Data as of 9 a.m. this morning from the WHO website indicates about 55.6 million cases with 14.1 million active cases reported globally. There were 12 million cases in the Latin American and region alone, with 27,000 of those cases and about 4,800 deaths in the Caribbean region. This pandemic is as much a health crisis as a social and economic threat, creating extremely challenging situations, particularly amongst the most vulnerable, and has unmasked some ugly truths about the challenges to our health systems. Like COVID-19, the ongoing threat from the Ebola virus disease in sub-Saharan Africa remains a real threat to our regions as well. And it could arrive here in the same way that COVID-19 did. The Caribbean Public Health Agency, along with its partners in the Regional Coordinating Mechanism for Health Security, has led the region's response, which enables the sharing of experiences and resources across the regions. Time will not permit me to elaborate on the re-emergence of the diseases such as tuberculosis associated with the HIV/AIDS pandemic, and the fact that only the Uruguay and the islands of the Caribbean have been spared from the scourge of cholera. A false alarm about a case diagnosed with polio in Venezuela, where the disease has been eradicated since 1989, was also a wake-up call for the region. However, mass migration and population displacing resulting in lack of access to and loss of follow-up for healthcare, as well as increased vulnerability among unimmunized children, has led to the re-emergence of other infectious diseases, such as diphtheria. The presence of any of these health threats in one country is a threat to the entire region. In closing, the experience with CHIKV and Zika, measles and cholera outbreaks in the region of the Americas highlights the importance of preparedness, strengthening surveillance systems, improving laboratory capacity, and a rapid response to outbreaks, but also underscores the importance of maintaining essential services such as our continued surveillance, reporting, and in maintaining the essential immunization services that we have seen gains over the years. And with that, I would like to thank you for your attention.
Thank you so very much, Dr. Fletcher Larty, to give us the perspective from CARFA. And I know you lead CARFA with a lot of vim and vigor and enthusiasm because you keep us all going, right? So you shared with us the fact that although Latin America and the Caribbean are diverse, we share a lot of similarities.
Yes.
You spoke about in the Caribbean here, we are diverse and we are susceptible to, because of our socioeconomic state or natural disasters and the dependence on travel and tourism, which is very, very vital to our living, our life and living. And then you shared for us all the various viruses and bacteria that have threatened the region in the last 10 years: dengue, cholera, malaria, norovirus, chikungunya, Zika, influenza, and of course the novel coronavirus. And even as we move towards the season, you're telling us as well too that not only do we have COVID coming on, but we also have dengue and influenza. And of course, you showed us the wonderful work that CARFA is doing in helping the region to pay attention to prevention, control, and an appropriate response to these emerging infectious diseases. So thank you very, very, very much. We very much appreciate your contributions this morning. And then we're going to have our next speaker. He is Dr. Wilmore Webley. He's an associate professor of microbiology and the director of pre-med and pre-health advising at the University of Massachusetts in Amherst, where he mentors students who are desirous of being accepted to various healthcare programs. He has made a lot of contributions over during his career to the field of microbiology, vaccinology, and allergy and immunology. And I guess maybe that's why he's here today on the panel. He's going to share some of that with us. He's a graduate from our own very Northern Caribbean University and also from the University of Massachusetts in Amherst. And he's the recipient of various awards and scholarships, including also a Fulbright scholarship, as Dr. Brower did as well. So without further ado, I invite him now to speak from his perspective as an immunologist and a vaccinologist as it relates to these re-emerging and emerging infectious diseases that are affecting us here in the region today. Dr. Webley, please. Dr. Webley, you need to unmute, please. Thank you. Yes, you should be good now. Thank you.
Thank you so much, Dr. Samuels. Thank you so much to the Ministry of Health and Wellness. You're under great leadership. The Honorable Christopher Tufton. Dr. Tufton is a great leader there. Dr. McKenzie, Dr. Webster Kerr. I also want to thank Nicole Martin Chen for the invitation. For the speakers before me, great information. I've learned a lot already. Thank you so much, Dr. Fletcher. I'll be doing what essentially is an overview of what I see as some of the greatest challenges and some of the reasons why these are current challenges. And inevitably, I'll be repeating some of what has been said before. But let me move on here. So you saw this graph from a similar image from our first speaker, where you see infectious diseases across the world. And what you'll see is that in the Latin American Caribbean regions, the diseases that we are suffering from are ones that are mostly vector-borne and ones that are also driven by climate change, which there are many deniers of. But when you look at the dramatic increases in some of these vector-borne diseases, it's just undeniable. And so one of the things that if you consider when these pop up and you track overall climate differences, it really matches up to some of these things. So I will spend a little time talking about climate change. But I also want to look a little bit at some of these diseases, dengue, chikungunya, of course, Zika, that of course share one common entity, that they are mosquito-borne and can readily be transmitted at the same time in similar individuals. So this is this is a graph showing you the outbreak of dengue in the Latin American region. As you can see, Honduras has really suffered from dengue outbreak. And overall, you can see that the entire region has had significant issues where that is concerned. When you look at the latest data, or the 2019 data, you can see that there was an increase, a significant increase in the number of cases of dengue in the region. The question becomes, why is one having this? And because dengue has been one of the consistent vector-borne diseases in the region, one of the things to look at is what else is co-infecting with dengue. And this is a good way to actually gauge what are some of the other things that we might need to now start thinking about and worrying about. And as you can see there, we've long dealt with issues like leptospirosis, but you're seeing Arapucci virus, your Mayara virus, Zika, CHIKV, the influenza virus, we're seeing in individuals who have dengue. You're also seeing hantavirus, which is one of those that I think we really need to keep an eye on, because at any point one can have a really significant outbreak of hantavirus. But as you look down this list, what you see are a list of combination of bacterial and viral pathogens that can become significant players in terms of infectious disease outbreak and morbidity and mortality in this region. And again, like my fellow, the former speakers have said, the travel, the interconnectedness of the region lends itself to this type of issue. Approximately 500 million people in the Americas are at risk for dengue. And, you know, I thank CARFA for the great work that they've done in working on this. But again, the problem is the distribution of the Aedes aegypti mosquito. And when you look at it, you saw a similar graph here for dengue, CHIKV, Zika. You can see that over time, you're having that kind of intermingling of these pathogens in the region. And as PAHO and others continue to follow, what you see is that again, a combination of these and shared vectors continue to be the problem. So you have dengue, you have a vector here. Typically it was the Aedes aegypti mosquito, but now we're seeing that the Aedes aegypti has become a regular transmitter of these diseases. And from a microbiological perspective, it makes you wonder what has changed in the pathogen that has allowed it to become so comfortable in a new vector, even though they're close related cousins. And I'll show you a little bit why this is concerning. Again, yellow fever, because again of a common vector, it's a continued threat that one has to look at. And then the tick-borne diseases, as the temperatures have increased, as we've had more variations in weather, more wild variations in weather, Powassan and some of these other illnesses become a challenge. And when you start having microbial infections in individuals, then treatment becomes more challenging and more difficult. And so that's really what this table is showing. It's showing transmission routes of mainly these flaviviruses and the families of viruses associated with it and the common vector routes that continue to increase. And then the mortality and morbidity associated with these diseases are pretty significant. And so when we look at these flaviviruses, you can see that encephalitis, cognitive impairment, paralysis can result from these. But even the visceral kind of diseases, the hemorrhage that it can cause, vascular leakages, damage to the liver become significant as well. And we know for Zika, for example, problems with congenital infection and the effect that it can have on the unborn fetus is a cause for worry. And so as we look across the region, the question is, what are we seeing here as we look at something like Zika in the Latin American Caribbean zone? Well, what caught my eye was Cuba and Montserrat, that their levels of infection were sporadic, even in the 2015 to 2017, 2018 region. And I went about searching for why is it that Cuba seemed to have had a handle on this. And it's all about mitigation. Cuba doesn't wait to have these mosquito-borne diseases to strike. They plan for it. The other thing that they do is that they go about fumigating the moment they have somebody who is positive. They have a group of over 15,000 workers in addition to their regular healthcare staff who go out and they go to these houses. They fumigate all the houses within 100 meters of where that one was positive. And if they get a second outbreak, they extend that radius to about 300 meters. They take any infected person into the hospital where you're quarantined and treated before being released back into the environment. And Cuba started doing this after their 1981 outbreak of dengue that killed about 158 people. And they decided that they just didn't want this to happen again. And so as we look at the region, the question is, what are the mitigations that we can have? And it seemed to me that the vector has to be something that we look at. It's the same thing for chikungunya. Here's the distribution, again, of chikungunya. And this is one of those cases where before the 2000s, this disease did not exist in the Western Hemisphere. And what we see is that we have a sylvatic, misspelling here, so sylvatic is a sylvatic transmission where it went through animals, typically non-human primates, and you actually had the Aedes falciparum was the common one, and then of course your Aedes aegypti picked it up. And what we noticed when you look at this genetic sequencing, there's actually a genetic mutation at residue 266 in the fusion glycoprotein 1 that the virus uses to infect. And that mutation actually led it to be able to infect and be transmitted by Aedes albopictus. And that now extended the range of the virus from just being in the Asian region to actually coming to be wider spread in Latin America and Caribbean. And these are some of the things that we'll need to start tracking to see that these changes in genetics. And so this is a map showing actually the spread of chikungunya from essentially in the Philippines. So this yellow one that spread to Jamaica and the Cayman Islands and Mexico and all of these Eastern Caribbean regions came directly from the Philippines. But as it came into the region, it started mutating. And so you can see different clades of it in these different colors here, in your purple and your blue and your pink, just seeding the entire region. And these changes are not just accidental many times. They actually give certain fitness. And so here, for example, you're looking at amino acid variations in the E1 gene and the E2 gene of CHIKV. And what it does, it has enhanced dissemination, it has enhanced infectivity, it has enhanced transmission in the population overall. And so as you look across the regions, the global distribution of it, you see these strains that are common to specific regions, but also are getting into new locales. So in my estimation, something has to be done about the mosquitoes. And what Australia and now Malaysia and some other countries are doing, is that they're looking at using Wolbachia as a mitigation treatment, where you actually deliberately infect mosquitoes with Wolbachia. They found this out at Harvard many years ago, that mosquitoes infected with Wolbachia weren't good at transmitting certain infectious viruses. And so if you have a Wolbachia infected mosquito that now bites somebody who is infected with dengue or chikungunya or Zika, the mosquito will pick up the virus. But when they go now, the virus will not grow at the level that it would when it would not go through the cycle. And so when it infects another person who is susceptible, you will not have transmission, or the rate of transmission would be much lower. And so that could be a mitigation event. When we are strapped with a pandemic like coronavirus, COVID-19, what it does is that it takes attention of other diseases that are disease burden in the region. And that could include everything from your Chagas disease to your schistosomiasis, and even chlamydia, which is what I work on primarily. Chlamydia trachomatis continues to be the leading cause of bacterial sexually transmitted disease worldwide, one for which we don't have a vaccine, and for which treatment is variable. Treatment success is variable. And so one has to also keep an eye on these. But I want to spend just the last few minutes on climate change and the impact that climate change has on the spread of infectious disease. So as we continue to have increasing CO2 levels and rising temperatures, we have extreme weather, rising sea levels, and this now leads to changes in vector ecology. And essentially, this changes in vector ecology means that you're having warmer periods extending beyond where they normally would stop. And that now extends the proliferation of the vectors for like malaria and dengue and hantavirus, Lyme disease, so you're talking about mosquitoes, ticks, and other vector-borne or arthropod-borne diseases. You start having increases in respiratory diseases like allergies and asthma. But you also have changes in water quality. And we know that after each one of these disasters, after every big hurricane, for example, you have an increase in certain infectious diseases. You have an increase in certain outbreaks because of contamination of sewer water with regular running water. You have streams and gullies and rivers get overflown and overgrown with certain pathogens. But these regions here are very important to health and overall transmission of disease. And as we continue to experience a warming climate, especially for areas that were already temperate, like Latin America and the Caribbean, we're going to have to look at this. Finally, influenza continues to be a challenge to the area. And of course, antimicrobial resistance will continue to be something that we have to look at and have to pay attention to. Stuff like your KPCs and your CREs are prevalent in the Latin American and the Caribbean region. And I'll stop there.
Thank you so very, very much, Dr. Webley. You gave us a perspective that is a little bit different from that presented prior. You spoke to the diversity of these diseases as it relates to climate change, and you paid special attention to dengue. And dengue we have with us for quite some time in the region, as you know, but now you're telling us we shouldn't just pay attention to dengue, we should look out for other co-infections, other co-viral infections. So dengue may be what we'll be looking at, but there are other reasons why the virus is here with us. You also spoke about Cuba, and Cuba we think is doing very well. Not only did it do very well with mitigation effects, as it relates to dengue, but as you know, it's also been doing very well with mitigation effects as it relates to COVID. The medical brigade, the fact that they go door to door to do surveillance activities every day with everybody who lives in Cuba, and then they do their surveillance for diseases, and then they intervene as appropriate. That's a lesson we need to learn from Cuba, because they're really doing well. So I really appreciate that. And then of course, chikungunya. Everybody in Jamaica can remember when they experienced their chikungunya. what we were doing when we got that first pain. And you are telling us that not only is it spread by the Aedes aegypti mosquito, but we should recognize that albopictus is there as well too. And the clade of the chikungunya is also changing. And then, of course, there is the Wolbachia and other issues as it relates to climate change. So you told us a lot, and we really appreciate your perspective, and we will pay attention as we move forwards in trying to get rid of these viruses and bacteria, drug resistance bacteria in our midst. Thank you. And our final speaker is well known to all of us. I don't know why I need notes because I know Karen so well. So Dr. Karen Webster Carr is our Principal Medical Officer of Health and the National Epidemiologist in the Ministry of Health and Wellness here in Jamaica. She's a public health expert, and she has led the response to a large urban outbreak of malaria. This is 44 years after it was eradicated from Jamaica, and she wrote her doctoral thesis was about this, and she really contributed to leading the elimination efforts of malaria from Jamaica. All of us in Jamaica have also benefited from Karen's expertise in epidemiology and research. We know that she has been leading the epidemiologic on the team on the COVID-19 outbreak. We know that she leads she's a principal investigator for the CDC's surveillance and response to the avian pandemic influenza. And she also led Jamaica's response to the chikungunya outbreak of 2014. And she's also led our dengue fever outbreaks, which she will tell you has been with us now for over 20 years, and we are about to enter the dengue season. So let us hear from Karen. Let's hear what she has to tell us, because I'm sure it's all going to be very exciting.
Thank you.
Karen, what a wide smile. Thank you.
Thank you, Professor Christie. There's a lot of embellishment that went into that. But thank you very much. I would like to thank the National Health Research Conference Committee, led by Dr. Andreen Grant, for inviting me and for producing this under very trying situation. So thank you to the committee. I will now share where we are. Many of us would know that the largest dengue outbreak we had was in 1977. Dengue was around before that, but we had our largest since then. The little arrow shows the outbreaks that have occurred since then. Many of us will remember HIV and its introduction. Some of us, at 35, I'm too young to remember that, but I do remember it. The malaria outbreak that gave me my first gray hair was in 2006. We have re-eliminated, but it's still on the slide because the threat continues. Chikungunya in 2014, Zika in 2016, and then SARS-CoV-2, COVID-19 in 2020. A very busy period for all of us in Jamaica. And we recognize that this is a bigger issue, and it's not just what we have seen here. The risks are greater. We have the risk of the communicable diseases that are vaccine preventable. We have eliminated many of them, but the risk is still there. The risk continues for the vector-borne diseases, yellow fever, malaria, filariasis. I remember when we were in our outbreak for malaria, Dr. Keith Carter reminded us the same way malaria came here from the same country, filariasis is a possibility. and also Ebola virus disease. And this is just, I'm sure, a few of what we are at risk for. Last night, I changed the mood of my presentation. We have to look broader than giving the numbers and so on. Why are we vulnerable to some of these diseases? What are our health vulnerabilities and our social vulnerabilities, and how are they linked to our outcomes? And we should use the information, and this is a charge to myself and to the academic community. How can we link these? So the Jamaica Health and Lifestyle Survey of 2017 revealed that 1 out of 2 persons in their 20 to 64 age group, the workforce, we can say, are have 1 or more of the 6 more common comorbidities. 1 out of 6 have 2 or more. 1 out of 20 have 3 or more. This is very important information. What is the geographical spread of these diseases or underlying conditions for these underlying conditions? And this is just one of the maps that we did showing the prevalence and the weighted counts for the workforce. Then we look at the older population. 4 out of 5, that's 80%, have 1 or more of the comorbidities. So we have to look at these vulnerabilities. We also need to look at what are the community or the social vulnerabilities that they are. This is what we came up with. This is also part of the Jam COVID app. So the vulnerable populations are flagged on the Jam COVID app. If you listen to what Deshaun said early on, this is some of the vulnerability that we put on the map to say where are persons going and what are the likely outcomes. So I think I wanted to bring that into the conversation. Malaria is still a threat. We spent, as Mrs. Huntley-Jones here, we spent many days and nights, Christmas, Easter, sleeping to ensure we identified the cases quickly, we treated quickly, and we had a very systematic way of vector control, public education, and intersectoral collaboration. But when we haven't seen malaria, then we get a bit complacent and we don't recognize it if it's not in a person who has not traveled to an endemic country. And we would not want history to repeat itself. So when I get the chance, I do speak that we need to remember malaria. And we did become free of malaria again. So we look at the arboviruses, and it is amazing. Thousands of Jamaicans we have reported have these conditions. This does not include the unreported. And we see for dengue that dengue has become more frequent, the outbreaks, and the inter-epidemic period, the number of cases reported are also increasing. The features of hyperendemicity. And we see all 4 serotypes. And the year we had 2016, we had the Zika outbreak. We had all 3 arboviruses circulating at the same time. So can you imagine what happened? Our most recent dengue outbreak, 2018, 2019, and a bit into 2020, showed that our children were the most vulnerable. And also, so many persons were hospitalized, and the direct hospital costs is just part of the situation. There's a lot of human and social costs related to dengue. And we spent over a year, going on 2 years in a dengue outbreak. Thankfully, we are out of the dengue outbreak right now. Of the persons hospitalized over the last 2 years, about almost 4% died. And I tell you, for us in EPI, going through these cases is heartrending. I remember one member of the team was so distraught, brought us to tears when we have to review the deaths. So, and we can't just imagine for the families who have died. Then we do have chikungunya, which we know many of us who had chikungunya felt and the pain of chikungunya. And it spread throughout the country in 2014. What we found out later through the health and lifestyle, that 80% of persons in Jamaica had chikungunya. Amazing. The parishes, the distribution by parishes is shown, with the easternmost parishes having the greatest prevalence of chikungunya. Why? Out to the researchers, why? So as we know, as age increases, the risk of death for many of these communicable diseases increases. Then in 2016, we had Zika, and with other issues related with Zika, Guillain-Barré syndrome, as well as other neurological diseases and congenital syndromes. So when we look at the geographical distribution for Zika and the congenital syndrome associated with Zika, we had this picture with the darker areas having the higher incidence of reported Zika, and the larger the dot, the greater the incidence of CSAS. Just to say, when we looked at the leading cause of death for Jamaicans under 5, in 2000 and 2016, the rates of congenital malformation increased. In 2016, it was twice what it was. And what we had in 2016, Zika. So, COVID-19, this is where we are as of yesterday. 10,088 confirmed cases and 616 cases that have occurred in the last 2 weeks. When we look at over the last 16 weeks, the changes that have occurred in the communities, this is what we have. So you note when we would have changed to community transmission, because it became very pinker in that period. There's some seem to have been some lightening of the colors, but over the last week or two, we are noting that there are some increases in cases. And this is our weekly epi curve. I thought it would be easier to see. And in this curve, the deaths lag about 2 weeks after the increase in cases. Just to say the note, we are in week 47, but week 46, you see that starting to increase. When we look at the positivity, we peaked in week 38, I believe, and we are coming down nicely, but over the last 3-4 weeks, we've kind of plateaued around the 10, just under 10. And we are hoping that this continues and that we will see some improvement. Just to say, our case fatality ratio increases as age increases, which happens around the world, but where we have most of our cases are in the young persons 30 to 39, and the ages around that, and least among the children, which we suspect because they are not at school. But the older person is not that different from the younger person, and that is concerning. Men are significantly more likely to die from COVID-19 than females, 1.5 times, 1.5 times more likely. When we look at parishes, there is a difference seen by parish, and we need to explore this a little bit more. This is our reproductive rate, which shows that we are hovering right now round about 1, which means that we are continuing. So this is a sneak preview for later this evening. We're going to be talking about these scenarios, what happens if we continue how we're doing, if we decrease. So see you later at 6 o'clock for COVID conversation. Thank you very much.
Much, Dr. Webster Carr, for, as usual, educating us so very well on these pathogens that we have with us. You went over malaria, dengue, chikungunya, Zika, and COVID from your perspective, which is the best perspective because you're the lady who leads the epidemiological analysis of the data that's coming into us. And most important, as co-PI of the Jamaica Health and Lifestyle Survey, you reminded us that Jamaicans are very much at risk with a wide variety of comorbidities for many of these illnesses. So thank you very, very much. I think this brings to the end the 4 speakers that have spoken to us, and I don't know if maybe at this point we could take 1 or 2 questions from the person who is assisting us with questions. Do we have time? Have we gone overboard? And if there are no questions, maybe I can ask a question. I don't know if anyone wants to speak to vaccine coverage rates across the region and how we're doing as it relates to the fact that diphtheria seems to be out there, measles, as we heard, seems to be out there. I know Jamaica has done really well, but I just wondered if anybody could speak to that. And if not, that's okay, but we just want to be sure that we are covering all our bases.
Vaccine coverage continues to be something that has to be closely monitored. You know, a vaccine is only good if it's in the person. And the fact that you have a good vaccine, if people are not taking it, that's problematic. And we saw in Haiti, for example, an increase in diphtheria when their DPT vaccine rate went down. The anti-vax movement, the Latin American Caribbean region is not immune to it. And as the anti-vax movement has increased, we've seen more and more people go on social media and kind of follow those and are resistant to immunizing their children because of these fears coming out of the modern anti-vax movement. So, again, the Jamaica is one of those countries that has done extremely well in vaccine coverage. I think all of the countries in the region, because of exactly the reasons we talked about, the interconnectedness, the travel, really need to get together and ensure that for the entire region, the vaccine coverage is maintained.
Okay.
There are several questions in the chat. I'm not sure that in the question and answer section, I'm not sure if we have time for them.
Yes, I realize that. I think there was supposed to be somebody who was going through the questions at this point. I'm not seeing them very well.
Okay, there is a question that asks, does climate change have an impact on our ability in the Latin American and Caribbean region to manage the immersion of infectious diseases?
And if Dr. Bauer wanted to take that, or
Climate change and infectious diseases, yeah.
Yeah, climate change definitely is complicating things. It's moving vectors around to areas that haven't previously been there. It's also displacing people, which I think is going to be even a bigger issue in the future. So climate change will continue to be making it more complicated in our response, and also trying to think of strategies to predict which areas may be most affected by emerging infections.
Thank you. Any other questions? Do we have time for any other questions from the chat?
How prepared is the Caribbean for a COVID-19 vaccine?
Sounds like Dr. Fletcher Carty.
Yes, it was directed to Dr. Fletcher Carty.
Hi, thank you for the question. So what I do know is that the regional governments are working together with the Pan American Health Organization and in collaboration with CARPHA to ensure that our countries in the Caribbean region are able to make their down payments to the COVID-19 vaccine facility. And this is a means of securing a vaccine when one is actually produced. So that is major progress has been made in terms of securing the down payments. And I know also that the ministries of health across our member states are currently evaluating their preparedness and their ability to respond and to deliver a vaccine safely. So work is happening on the ground in preparation for when we do actually have a vaccine available. Over.
Thank you.
There's a follow-up question to that. Thank you. I'm wondering, for the Caribbean, which vaccine are we going to pay for? Is it the Chinese one, or the Russian one, or the American one? Or are we going to assess the vaccine? How do we assess that the vaccine we're getting is good for our population? So we have to be careful. We have to think about it. We have to discuss it. We don't just put our money and go pay for which vaccine. We have to know which one we are getting. And as a region, we have to, think about it. And one more question. We've been treating coronavirus. We've not told each other, how are we managing it? How are we treating it? Do we have something we are using within our own Caribbean context that has been helping our people to recover? We have so many persons have recovered. So are those made available to everybody? So we know. So as a region, we can take care of ourselves. We can't be depending on everybody. Thank you.
Thank you. Those are very good comments. And I think for the first one, I would say, yes, it's early days yet. The information that we have is very, very helpful and very nice to know. But I think we need to see the peer-reviewed publications to tell us more about this. So as time goes by, I'm sure we will hear more. And of course, our region, PAHO, CARPHA, they will be looking out for all of us to make sure that whatever vaccine comes to us, it's a vaccine that is appropriate, it's safe, and everything is good about it. So I don't think we should worry too much. The work is ongoing and it will be done well. And as it relates to treatment, CARPHA, PAHO, individual hospitals, individual countries have been working together with using guidelines for treatment and prevention on the ground across the region. And whatever is available out there, we actually use it. Now, there are some drugs that have been approved that and efficacious for COVID-19. So for example, dexamethasone is one that I know that it's cheap and I know it's available to almost everyone. Some of the other drugs, learning more about those as we go along. And of course, there are also other medications. We also give oxygen, intravenous fluids, ventilator support, and so on. I think I'm frozen.
I just wanted to comment on the vaccine issue because that has been something that a lot of people are concerned about. I did a webinar a couple of weeks ago on that with in Jamaica as well. I want to allay your fears. enough people in the world who know how vaccines should work and who understand what the data means have eyes on this. And so you don't have to worry. Nobody is going to take or approve a vaccine that doesn't work. Of course, there's still questions underlying because the two vaccines that have made it to the front of the line are new platforms. We've never had an mRNA vaccine before. And so we really don't know what other issues could come up with it. And that is why they will continue to monitor these patients in both, these participants in both arms of the study. But be assured that we're not going to get the Russian ones and the Chinese ones because they haven't gone through phase 3 clinical trials yet. And while the Russians and the Chinese have approved them, they're only approved for the military in those countries. And so there's really no intent that anybody in the Western world or in general will actually utilize those as vaccines unless and until they've been shown to be efficacious and safe in the phases of clinical trial.
Thank you. Well said.
Celia, if I may just jump in
Yes,
too
please.
and add.
I would like for you to do that.
Yes, thank you. Also, to let you know that the Caribbean Public Health Agency also has the Caribbean regulatory system that monitors, therapeutics. So we have systems in the region and we are working very closely with PAHO, the Pan American Health Organization, to set up systems for monitoring of vaccines. And this is something we do routinely for other medications and other vaccines that we use for our childhood immunization programs. So these systems are already in place and we are building and preparing for what may come. So rest assured that there are systems and mechanisms in place to protect the Caribbean region, based on our mandate that we have been given by the people of the Caribbean.
Thank you. Well said. Thank you so much. And I'm going to ask Karen to close with the last comment. Someone is asking, please, about Christmas. How do we prepare for Christmas? I know this is a sneak preview, but not everybody will sign on at 6. So would you share a little bit about your 6 o'clock presentation? That's a question on the chat.
I can't share all the Christmas, but we have to do Christmas safe. It comes down to that. And the short interaction with our family, we have to ensure that we don't do the parties, the large family dinners. And if we're going to do family dinners, preferably just your immediate family. And if you're going to introduce others, we'll give you further tips how to do that. If you're a different household, sitting at separate tables and so on, which is not necessarily going to work in our situation because we love to socialize. For sure, what we saw in the Emancipation, Independence weekend was what we used to model the scenario for Christmas. And we know Christmas can be much worse. If what happens over Emancipation, Independence Week, we will likely to exceed our health system capacity by Christmas Day. And so for me, doing the scenarios over last night and as well as 10 days before, because we have increased since 10 days ago, it's looking, it is very sobering where we could be around Christmas. So all of us would have to ensure that we live responsibly in the Christmas season so that all of us as Jamaicans will survive to 2021. And so this is my last message to the group. Thank you.
Thank you very much. Thank you very much. And so I want to thank the panel, Dr. Brar, Dr. Webster Carr, Dr. Fletcher Clarty, and Dr. Webley for their distinguished presentations, for the information that they shared about the emerging pathogens in the region and what we can do to mitigate them. And of course, how we're going to cope with the new vaccine that is coming on board. And of course, how we're going to celebrate Christmas in a safe way. And with that, we are now over time. And I just want to thank you all. I want to also thank the organizers and thank the audience for your participation. Thank you very, very much. Please enjoy the rest of the conference.
Welcome.
Hello? 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 Yeah, you. Hold on, and a pandemic winner. You're now wearing a mask, you're now washing your hand, and you now keep the required 6 feet distancing from other people. And what could I really cause you? You need to stop it. That no mask, no wash, and no distance something there, nah keep. You know what keep? COVID-19. Yeah, it not gone nowhere. COVID-19, they are same way. So here why you are going to do for all of we. Wear your mask, wash or sanitize your hands pan a regular, and yeah, keep your distance, please. And thanks.
Healthcare workers are working very hard to ensure lives are saved and people recover quickly from COVID-19. But their work is becoming harder because you're not wearing your mask, washing your hands with soap and water, or using hand sanitizer, and you are not maintaining physical distance. Let's limit the need for hospital beds and ventilators. Do the right thing. Cover your nose and mouth with a mask. Practice good hand hygiene and maintain a physical distance of 6 feet between you and others. COVID-19 is not over. Protect yourself while protecting others. A message from the Ministry of Health and Wellness. COVID-19 is still here. Always wear your mask correctly while in public places, covering your nose and mouth at all times. Masks should never be worn over the head, under your chin, below your nose, or hanging from your ears. Recovery from COVID-19 can take up to 60 days or more. The mask or the ventilator? You choose. A message from the Ministry of Health and Wellness.
Oh, you mean when I talking or?
When you're talking.
Good afternoon. Good afternoon, everyone. I am Dr. Nadine Williams, the Director, Health Services Planning and Integration here at the Ministry of Health and Wellness. And I first of all would like to say congratulations to the EPI unit, Drs. Webster Carr, Dr. Grant, for what has been an excellent conference so far. I would like to say that as we welcome you to this, our second scientific session, it is important that we think about the topic we are to consider, and that is mental health. The fear that mental health pandemic was going to follow on the heels of the COVID pandemic, which is what was projected in the first instance, really has not in entirety been realized, because the mental health impact is evident as we speak. It is therefore a global imperative that mental health be considered. Another projection was that children were not going to be affected with this disease. The fact of the matter is that children are affected, and therefore it is quite appropriate that we consider the impact of COVID-19 in children and the mental health impact that is manifesting. And so it brings me great pleasure as we put these two topics together to introduce Dr. Ganesh Shetty. Dr. Shetty comes to us today and he speaks to us about children and their mental health consequences in this COVID-19 pandemic. And so his title of his presentation is Coping with COVID-19, Helping Our Youth with Tele-Mental Health. Dr. Shetty is a child and adult psychiatrist, a certified child and play therapist, a certified clinical supervisor. He is a naturalized Jamaican, currently employed by KSA Health Department. He has worked at various child guidance clinics, schools, and communities in the region. He also works at the University of Technology and has his private practice. In collaboration with NGOs, Dr. Shetty and his team have trained community-based youth workers and teachers in inner city communities, including those in Augustown recently. He played a significant role in starting of the Saturday Clinic for Sexually Abused Children of Children's Homes at Comprehensive Health Center, and since the COVID-19 pandemic, starting an adolescent tele-mental health service in the KSA. He comes to speak to us about this today, and it brings me great pleasure to introduce someone who I have known since we were in the trenches together as senior house officers at the Kingston Public Hospital. Please help me welcome Dr. Ganesh Shetty. Dr. Shetty, over to you.
Good afternoon, ladies and gentlemen. I want to thank and appreciate the hard work the Ministry of Health and the leadership of Minister Dr. Tufton have put in so that we are where we are and not worse. And when the pandemic hit, we were affected. We were wondering what to do so we can continue our coverage. And some of the clinicians working in the system joined together, got some credit to our funds towards this effort. And we started in Kingston St. Andrew Health Center covered 2 clinics, what we call telemental health. And the next month, we encourage the Flow Foundation to donate the coverage of the phones for the next month. By that time, we were fortunate to know that Minister of Health, Child and Mental Health Services, under leadership of Dr. Laiba, could get the Minister of Education and UNICEF to assist us. And by that, we are having 50 phones given to 50 clinicians working all over the island to use it to connect with the kids and their parents. I am having a little challenge to show my screen. Can somebody help me to do that? It doesn't say screen, it says Google Drive. Okay, I will just continue. Unfortunately, my presentation cannot be shown. So initially, we started it, and we did 6 months of that from March to September, and we thought we need to look at whether the services are acceptable, accessible, and effective to help the children and the parents with mental disorders. And when we looked at putting together this presentation, we found out that there are so many persons, even before pandemic, using the telemental health over the years and have found it effective and acceptable and accessible. And okay. When we looked at the number of sessions we had last year for the period of March to September, and this year, actually, we had similar amount of sessions, similar number of sessions done. That is, we had seen 494 children in 1,632 sessions, and another 179 sessions which were face-to-face because of the situation. So we had 1,811 sessions over the past 6 months. And this is actually a small increase in the number of sessions compared to the same period last year. And what is important is the missed sessions. Before, we had nearly about 40% of children would not keep up the appointment. And when we analyzed that data, we found that most of these children are adolescents who are showing significant behavioral problems. And if untreated, they are likely to deteriorate, and at least some of them might become more aggressive, and some of them might even join gangs and indulge in unlawful activities. So it was very important to reduce this missed appointment. And what we found is that we had reduced the missed appointment using the telemental health by half, from 39% for the last year for the same period of March to September to 19% this year. So when we looked at the literature, before that, we came with 2 questions. We want to find out if parents and caregivers and the patients find telemental health feasible, accessible, acceptable, and want it to continue. And also we wanted to find out if the responses of the patients who are, for this sample, adolescents between 11 and 18 years, and the parents differ in how they perceive telemental health services, which are introduced in this instance to prevent exposure to COVID-19. And as I mentioned, we focused on the data from Kingston St. Andrew Health Department, the two child guidance clinic, one in Comprehensive Health Center, another one in Glenville Health Center. But I want to mention that this is still an ongoing study, and we want to collect data from other 40 clinicians working island-wide and see how it compares to our experience in Kingston St. Andrew. However, today's presentation is about our experience here. And we wanted to know if it can help us to understand and hopefully can assist Ministry of Health in policy decision making, whether even when we manage to contain COVID-19, we still might have to use the telemental health because it has already, as I mentioned, allowed us to have same number of sessions safely, as well as, more importantly, it has reduced the number of missed appointments. So when we look at the literature, there are quite several studies about telepsychiatric telemental health, and they are looked at legal and regulatory issues and whether it is effective. And there is a strong positive evidence to show that it is. And also some of the studies looked at how it is operationalized and implemented. And some clinics in US use the residential staff, and some others could also engage private practitioners to deliver telemental health from their own physical face to more number of clients. And that's something to think about also, considering that we have 95% of our target population not served by government child guidance clinic. And also some of them have looked at the drawbacks, which could include technical problems which may arise and the lack of rapport and that warmth and interpersonal space, which is created by face-to-face sessions.
1 second, if I may, Dr. Shetty.
Yes.
Thank you so much for your presentation thus far. It is so exciting and so interesting, and I'm sorry that you're having some difficulty. So the organizers have suggested that perhaps what we could do is that we could have you sort out that technological glitch, have Dr. Williams present first, and then we come back to your presentation. Would that be okay with you?
And that will be great, because I think there's a lot of stuff on the presentation.
Thank you so much. And so what we'll do at this time is that we will have them communicate with you. We apologize to the audience, which exceeds almost 700 persons now, and then we will move to Dr. Williams. Is that okay?
That's great, and I apologize.
Okay, excellent. So thanks very much. So I will just switch to Dr. Williams, and my namesake, Dr. Williams, is no stranger to the research platform. He is in-house, and he is a proud past student of the Kingston College. He's presently employed to the University Hospital and is well known to many of us. And he is a past president of the Jamaica Emergency Medicine Association, when he was president in 2004. He has published several articles, over 50 peer-reviewed journal articles, and presently he is a chairperson of the research committee in the Emergency Medicine Division. Dr. Williams was awarded the UWI's Principals Research Award in 2015 for the most outstanding research activity under the theme Emergency Medicine in the Region, Merging with Other Specialties. He teaches and examines both undergraduate and postgraduate students at the University of the West Indies, and is also an instructor for several life support courses, including the Advanced Trauma Life Support course, ATLS. Dr. Williams comes to us today with his research entitled Stress, Perceived and Coping Mechanisms of Medical Students During COVID-19 at the University of the West Indies, Mona, a rapid review. I think this is quite relevant, and I am looking forward to this presentation. Dr. Williams, over to you.
Thank you so much, Dr. Williams. I also would like to take this opportunity to thank the conference organizers for giving me this opportunity to speak on this topic. This is my very first time, and I'm happy to be here. You can. Okay. Before I go on, I'd like to acknowledge all my co-authors, not only from the Emergency Medicine Division, but also from Caribbean Institute for Health Research, the University of Technology, the Department of Psychiatry, and the Department of Biochemistry. Just by means of a background, there have been several studies conducted worldwide, and to my amazement, while I was doing this study, I was surprised to see so many studies that examine stress factors in medical students and their coping mechanism. As you can well imagine, stress is going to be a difficult terminology to define, but from one article, it is defined as an emotional disturbance that arises by stressors. Now, traditionally, stress factors can be classified into academic and non-academic. So an example of an academic stress factor is trying to pass your exams, whereas an example of a non-academic stress factor is financial challenges. Now, we were concerned about the COVID-19 pandemic as it disrupts the students and the teaching, and we found that this educational emergency put us in an opportunity to examine where we need to go. So on this background, the researchers embarked on this study. This is a picture of the students, and this was taken in the pre-COVID period, and my word, don't they look stressed? So the objectives of this study is, one, to determine the stress perceived by the MBBS students, and two, to determine the coping mechanism used by these students. We were happy to get on board the Dean's Office and the University Registrar, who assisted us in using the student's email to do this study. And this study was a descriptive cross-sectional design. So in terms of our students, we took a census of all registered MBBS students, and the data were collected using SurveyMonkey on an online platform. Of a possible 1,500 students, we had 308. This roughly results in a 30% response rate, which is a reasonable response rate for a cross-sectional study. And we got the approval of the ethics committee. So our inclusion criteria had all the medical students that were registered in the MBBS program at the time we were doing this study. And as you can see, we were able to get their consent electronically. And students who were not registered in this period of study were excluded. The data was analyzed using descriptive statistics, t-tests, and multiple linear regressions. So in this study, we had 3 instruments. The first one was the demographics, where we look at the usual age and gender. And the second instrument was the perceived stress scale, which I will speak about later on, as well as the third instrument, the brief COPE scale. So let's look at the perceived stress scale. This scale measures self-reported stress factors and is well established in terms of its reliability and its validity, and it's in the public domain, so we were able to access it. This scale, as the term suggests, PSS-10, consisted of 10 questions, as there are other versions that may have longer questions. And it was scored on a 5-point Likert scale from 0 to 4. Considering the time interval of the study, though, we wanted to capture rapidly the emotional response of the student's stress. So we modified the PSS into a 4-month extension, because originally it is really for a 1 month. So this is an example. As you can see, we are emphasizing the stressor as the COVID-19, and we modified by placing in the last 4 months. How often have you been upset of something happened unexpectedly, and so on? And the student or the responder will quantitatively select their response. So as you can well imagine, the maximum score that you can get from this 10-question questionnaire is 40. So what the instrument designer did was to divide the scores in categories such as low, moderate, and high, so we can apply quantitatively categories that we would be able to separate the degree of stress levels. So we're going to look at the brief COPE scale, the other instrument, but first of all, what is coping? Again, another difficult term to define, but from one author, it can be looked at as an effort used to maximize stress under negative life experiences. Again, this was a validated instrument that assessed a wide range of coping behaviors. It consisted this time of 28-item questionnaires that was divided into 2 sub-levels, with the coping mechanism on one hand being avoiding the stressor, and on the other hand approaching the stressor. Higher scores reflected better coping. So just briefly looking at this instrument that was established by Carver et al. Quite a while back, and this instrument created these coping mechanisms, and we are looking at now the approach category. And items 2 and 7, for example, is referring to 2 questions on the questionnaire that will be addressing active coping. And so the design of the questionnaire was powered and was structured in a way to lessen the uncertain answers. So all of these are coping strategies we use every day in our life. Right now I'm under stress and I'm using active coping. I'm planning to get around this stress. Emotional support, you can understand what that is. Use of informational support is like getting messages on your text. Well, the students would be getting information, facts, and to give them an update, and this can be used as a support strategy in the coping. Positive reframing, meaning making the best of times, is another coping strategy. And the others are self-explanatory. The other coping strategy is avoidant, avoiding the stress factor. Behavioral disengagement, just want to give you an idea of what that is withdrawing from the stress factors. And the others are self-explanatory. So this is a picture of the brief COPE scale. And as you can see, this responder is using the blue as their response. And what we do in this scale, we summarize or get the sum of the score in each individual and use it quantitatively in the instrument. So this is an example of two questions asking the same thing. Unfortunately, my slides got shifted. So focus the red dot lines on question 3 and 7 instead. 3 and 7, and these two questions are looking at the coping mechanism of denial. Number 3, I have been saying to myself, this isn't real. And number 7, I've been taking action to make a situation better. So that's all, just giving an example how the system works. Now, the new norm, mask up, temperature down, empty classrooms. Let's take a quick look at the results. In this study, we have a predominant female category. Majority were Jamaicans as expected. With regards to the students' perceptions, a great majority of students were moderate or high undergo or experience high perceived stress, as you can see. With regards to gender, females seem as if they were more stressed when you add up the moderate and high perceived stress when compared to the males. So female tend to stand out at this moment. And this is just something I'd probably mention, emphasizing the gender female. When we look at the descriptive statistics of the coping strategies, as you can see, the one in blue, acceptance, planning, self-destruction, and religion had the highest means, suggesting that these were the main coping mechanisms that the students use. And this is also when you look at the mean in either gender. But just to draw your attention in the p-values that I've bolded, emotional support and venting were mostly used by females. So the coping strategies were these. And looking at perceived stress, there was a wide variation of the different strategies. Now, the researchers were concerned about the dominance of the female, not only in the total population of the study, but in the pie chart that I showed you earlier, they seem to perceive stress more significantly. So we conducted two multiple linear regression, and using a hierarchical approach, we wanted to predict perceived stress. So the female category, we placed it in the age gender of this regression, and the male category, we let it remain as a reference category. So there were two models, and one of the reasons why we chose the female was clearly the females were more predominant. And when you look at model 1, what the result is saying is that if you were to predict the severity of stress, the females would have a factor of 2.4 more than the males. In model 2, we combine genders, female again, and in this time add the coping mechanism that were significant, as you can see their p-values. And from this regression, we can predict that gender along with these independent variables will impact the dependent variable of perceived stress and outcome in a significant manner. So this is just summarizing the findings of the models, first model and the second model using the regression. So in discussion then, there was a high perception of stress among the students. Females were significantly affected. The majority utilized active coping strategies, and we are aware from the regression that the perceived stress will vary based on the gender and the participants and their coping strategies employed. So in conclusion, There was a high perception of stress by medical students, and clearly we need to put this on the front burner. Interventional programs such as workshops to emphasize coping techniques should be helpful, not only in the universities, but this common formula can be applied in work areas. Certainly, this research brings and highlights that a curriculum for stress management and policy-driven strategies should be considered by the institution. There were some limitations, as you can see: cross-sectional design, findings cannot be generalized. We were unable to do comparative studies because the pandemic is new, so we have to wait and see what other studies reveal, and clearly further research is warranted. Thank you and stay safe.
I would like to thank I would like to thank Dr. Williams. I think something has. We had an. Is anyone? I would like to thank Dr. Williams for. I would like to thank Dr. Williams for his presentation. I think the last few slides weren't heard very clearly. I realized that I wasn't the only one who wasn't hearing the last 3 slides. I'm not sure how we're going. I know he was just winding up, and I think it would be a good idea if Dr. Williams just had the opportunity to share that the last 3 slides with us, please. I think it was the, no, not that slide, the one after that. Yes. Yes. Dr. Williams, if you could just read those for us, please.
Yes, thank you, Dr. Williams. So we concluded, the researchers concluded from this study that clearly there was a high perception of stress with regards to the COVID-19, of course, by the medical students. And we believe that we should take this opportunity to look at stress by introducing interventional programs such as workshops to apply to the students, to assess and to let them use the best coping strategies. Some of them came out of this study, and also to use a curriculum in the students' portfolio. We had some limitations in this study. A cross-sectional design has its drawbacks with sampling and convening. The students were posed questions that were specific, and the variability to apply their knowledge and feelings would be restricted. And so that was a limitation. The findings cannot be generalized because it was a single institution study. But furthermore, it was difficult to compare other regions who may have done similar studies because there were no published report to do a comparative study. And clearly further research is warranted. I think I was about to say thank you. The slides got out of control a little bit. I think that's Dr. Williams, that was the main points.
Thank you, Dr. Williams.
Thank you.
I think that the persons who had asked, who had said that they couldn't hear, are appreciative that you would have come back and explained. So thank you so much. I think that as Dr. Shetty gets ready, I would like to say that that's groundbreaking work, and certainly your findings in the medical students, we could think of how they could be applied to a more general audience in the workplace, in the hospitals, or healthcare workers. So I just want to say thank you so very much. We will take questions at the end of the session if we have the time, as we ask Dr. Shetty to return to the podium, this platform, as his slides are projected. Dr. Shetty, over to you.
Thank you, Dr. Williams. And I believe the presentation is being run, and I'm not seeing it.
You will see it shortly, Dr. Shetty.
Okay, just in the meantime, I want to recognize my co-authors, which is Dr. Judith Leiba, who is Director of Child and Mental Health Services in the Ministry of Health and Wellness, Professor Cynthia Onyefulo, who is Professor in Education in University of Technology, and Dr. Steve Weaver, who is a Senior Lecturer and the past Head of School of Nursing, Mona. And as I mentioned, we started off as a small project in Kingston St. Andrew, 2 child guidance clinics within that. And I mentioned also that Ministry of Health collaborated with Ministry of Education and UNICEF to extend it to the island with 50 clinicians getting 50 phones with data so they could conduct telemental health sessions. And having done this for 6 months, we wanted to see what is the acceptability, accessibility, and satisfaction of the children who we serve, as well as the parents. And this is a part of ongoing study because we don't have data from rest of the island. And also we want to use a mixed methodology to interview the clinicians because we also want to know what is their reaction and how they think about using telemental health and the response they get from the clients. Still not seeing my presentation. I'm supposed to do something. Am I supposed to share content on, or I don't know.
1 second, Dr. Shetty.
All right, I keep talking. So what would happen when we get all the data? We'll have information from the 20 clinic sites island-wide in terms of what the parents thought about telemental health, what the children, the clients thought about telemental health, as well as what the clinicians think about telemental health. And one of the things which struck when we looked at the data for the 6 months is that the number of sessions conducted using telemental health was slightly more than the number of sessions conducted last year for the same period, that's March to September. So we had about 1,811 sessions conducted using telemental health, whereas out of that, there are about 700 odd sessions conducted face-to-face because once there's a walk-in and there are some clients who had to be seen face-to-face, we found that the missed appointment reduced by half from 39% to 19%. And that's a big gain because when we had analyzed the profile of the children who missed the appointment, they happen to be teenagers who have severe behavior problems. And if they don't get the help, they're quite likely to deteriorate. And some of them become aggressive young people. And some of them also, unfortunately, might join life of crime. So they need the most help, but they're the ones who parents are not able to bring them to the clinic for one reason or the other. And so in other words, we are also saving about 40% of our clinicians' time, which was wasted just waiting on the patients who don't turn up. And we developed a questionnaire for a parent, and also we focus on the, okay, let's move forward. Next slide, please. Next slide. Next slide. Start moving. Next slide, please. Next. So I just mentioned about what we found in the literature. So this section of the presentation of the Briga research will only focus on the cross-sectional part of it, which we gave questionnaires to 50 patients and their parents, patients who are 11 to 18 years old. And we focused on 2 child guidance clinics in Kingston St. Andrew Health Department. Next, please. And both questionnaires had 15 items, and it had 4-point response scales, which are like certainly true, partly true, not true, and do not know. And there are also 3 open-ended items for the participants to express their views and likes and dislikes about telemental health, what they like most, what they like least, and so on. And the questionnaires were reliable with the reliability coefficients 0.959 for the adolescents and 0.837 for the parents and caregivers. And we use SPSS. Next, please. Of course, we got the permission and consent of parents and caregivers for the participants who are patients between 11 and 18 years. And of course, we deleted all the personal identifying information. Next, please. And the results for the research question, what are the perceptions of patients and their parents, caregivers on feasibility, accessibility, acceptability for the use of telemental health service in Jamaica during COVID-19? 13 of the 15 items were addressing this particular question and looking at feasibility in terms of economic cost reduced because of this modality, and also the scheduling consideration, waiting, and so on. And accessibility, whether they are able to access and use it comfortably, and how they are satisfied or not. Next, please. These are 2 questions which were particular to COVID. The table looks a little weird. And you can see that 90% of the parents and caregivers to the question whether they thought having telemental health prevented unnecessary exposure of themselves to COVID-19. 90% of the parents and caregivers said yes. And similar number of percentage of patients, the children between 11 and 18, also said that it prevented unnecessary exposure to the COVID-19 because they had to come to the bus or take a taxi and wait in the clinic area, which is general area with folks with all kind of problems. Next, please. Okay, but when we look at, compared those 2, there are not significant difference. Move forward, please. And next, please. Go back, go back, go back. Go back. Okay. This is when we asked them, did they think that it will, we asked the parents, do you think it will also prevent unnecessary exposure to your child or ward? And we asked the children whether they thought it will prevent unnecessary exposure of the parents and caregivers to COVID-19, and most of them agreed, as you can see. Next, please. Next, please. Okay, when looking at the parent and caregivers questionnaires, the questions were completed by majority mothers who were in charge of the patients, and fathers were also there, but very small number, 8%. Grandparents also, as well as caregivers, played an important role in having these young people come to the clinic. And 3/4 of the respondents were employed, and some were not employed. Small percentage, 4%, were self-employed, and others were inconsistently employed. They get a hustle or a gig somewhere. Next, please. And looking at the responses to the questions, parents did agree that reduced traveling time and cost, 93 and 94%. And they also thought it will reduce their waiting time on arrival to the clinic, 83% thought so, as well as the time they have to take from work. And if they are in a temporary work situation, it's kind of hard to get time off work to come to clinic, and sometimes as often as once in 2 weeks. They also felt that it will reduce less loss of classes for the child and ward. Next, please. And they were significantly comfortable with using the phone, 89%, as well as they thought, 83% thought the child and ward also were quite comfortable in using, as well as the technology was not a major problem. Next, please. And majority of parents and caregivers thought it is confidential, 88%, and convenient, 79%, for delivering mental health care to the child ward. And 3/4 of them did think that it was satisfying as seeing doctor or counselor face-to-face. And overall satisfaction, 85%, was good. Next, please. They did acknowledge 98% of them is saved them traveling time, traveling costs. Bus fare could be a big hindrance in some poor parents. And also waiting time and child missing class, as I mentioned. Next, please. And this is for the patient. They thought it was quite easy to maneuver the technology, 96%, and they're quite comfortable, 84 to 86% of times. And they thought their parents are also comfortable. And in terms of the patients, looking at whether they thought it is private and confidential, 88% said yes. And convenient, it was convenient to 90% of them. When talking to the counselor doctor, it was also satisfying to 73%. And they were happy 90% of the time that the help they received via this modality is good. Next, please. And when looking at, is there any difference between what patients and parents thought, caregivers thought about telemental health? When we looked at a couple of these items, which they're not significant difference. Next, please. So in effect, we concluded that telemental health service is effective and has generated hope for improved access and enhanced quality of care in Jamaica. And it supports that child and adolescent telemental health services feasible, accessible, acceptable modality of sustaining the delivery of child and adolescent mental health services during COVID-19. And I would add beyond, and significant reduction in missed appointment, which will lead to loss of professionals' precious time, is also significant from the data of this study. Thank you. And also thank my colleagues in the Child Guidance Clinic of Comprehensive Health Center in Glen Vincent. And I would also like to thank the support I got from Kingston St. Andrew Health Department, particularly Dr. Debbie Carrington and Dr. Heather Reed Jones, and of course from the region, Dr. Chambers. And I thank again the Minister of Health under the leadership of Dr. Tufton, placing so much emphasis on mental health because it is important. Thank you.
Thank you so much, Dr. Shetty. I think that that is another brilliant piece of work that has been described. And I really want to thank you, because what you have shown us is that in this context of COVID-19, there actually has been the new normal represents an increase in the quality of care, in the sense that if we're reducing the number of missed visits, if we are increasing the responses, if we are increasing accessibility, quality, and comprehensive care through the adaptability of this new strategy, then it means that we would have improved on the quality of service that we would have delivered. And I really want to say thank you for this, for you and your team for this excellent piece of work. I would like to invite two questions. They're being tracked, and so I will ask you to stand by to respond to two questions. And so please, or organizers, please relate these questions.
So for Dr. Williams, based on research, can we say that the mental health of female was more effective under stress due to their coping mechanism as compared to males?
Thank you for that question. When we examine the coping strategies that were used by the female subset of this population, overall, they had what we can term as a negative coping strategies because of the categories that they fall under. For example, denial, blaming, etc. So in terms of if they probably would be considered to be at a disadvantage in coping because these negative mechanisms do impair your psychological well-being in that it creates conflicts, and as such it may hinder going over the stressors, so to speak, in general.
Thank you, Dr. Williams. Could you also just remind us what year of study were the students in the experiment? What year of study were they?
Oh, thanks. That's a very good question. I did not expand on some other aspects of the study, but we partake in this study this 2020, and we invited all 5-year groups from year 1 to year 5. So it would have been going back maybe 2000, well, going ahead, 2020, it would involve all 5 years. So we could make other conclusions in the study by, for example, looking at year group. How does year 1 manage stress versus year 5? So that's an excellent question, and that's one of the projects because we have the data. Because as we know, year 1 is just coming in the system, and guess what? Year 5 is trying to come out by passing the exam. But it involved all present students that were registered in 2020, so all 5 years were included.
Okay, thank you, Dr. Williams. No further questions.
I would like to say thanks to Drs. Shetty and Dr. Williams for an excellent session. For those of you who have other questions, they're in the question and answer section, and they will be dealt with individually. And so I just want to say thank you for all the participation. Thanks to our two presenters, excellent section, and it certainly allows us to segue into the next section, which will be chaired by our past Director of Mental Health Services in the Ministry of Health and Wellness, Dr. Maureen Irons-Morgan, who is a consultant psychiatrist and who will chair the panel discussion, Striking the Balance in Health and Wellness. And so that will be our last section for today, our last session. And thanks again for being such an excellent audience. Dr. Irons-Morgan, over to you.
That's a 2 minutes break. All right, let me. You guys talking with your mask on? Yeah, take it off.
So there'll be a short 2-minute break. And
Then,
so we will.
Then Dr. Wright, then you.
At the end of the 2-minute break. So I would imagine that by 1:40, it gives us time to stand and stretch and reach for the stars.
Hello? 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 Yeah, you. Hold on, and a pandemic winner. You're now wearing a mask, you're now washing your hand, and you now keep the required 6 feet distancing from other people. And what could I really cause you? You need to stop it. That no mask, no wash, and no distance something there, nah keep. You know what keep? COVID-19. Yeah, it not gone nowhere. COVID-19, they are same way. So here what you are going to do for all of we. Wear your mask, wash or sanitize your hands pan a regular, and yeah, keep your distance, please. And thanks.
Healthcare workers are working very hard to ensure lives are saved and people recover quickly from COVID-19. But their work is becoming harder because you're not wearing your mask, washing your hands with soap and water, or using hand sanitizer, and you are not maintaining physical distance. Let's limit the need for hospital beds and ventilators. Do the right thing. Cover your nose and mouth with a mask. Practice good hand hygiene and maintain a physical distance of 6 feet between you and others. COVID-19 is not over. Protect yourself while protecting others. A message from the Ministry of Health and Wellness. COVID-19 is still here. Always wear your mask correctly while in public places, covering your nose and mouth at all times. Masks should never be worn over the head, under your chin, below your nose, or hanging from your ears. Recovery from COVID-19 can take up to 60 days or more. The mask or the ventilator? You choose. A message from the Ministry of Health and Wellness.
Good afternoon, all, and welcome to the panel discussion in this final segment of today's meeting for the National Health Research Conference. The topic we're looking at is striking the balance in health and wellness. We're very fortunate to have with us three very knowledgeable and competent presenters, Drs. Kai Morgan, Earl Wright, and Kevin Goldburn. And they will be making presentations in that same order. Now, how we're going to do it is that Each presenter will do a 10-minute presentation, and at the end of all three, we will have questions and answers. So I do want to encourage all our participants to write your questions and comments in the chat so that we will have them at the end of the presentations. In the interest of time, we will move right into the introduction for the first presenter. Our first presenter is a licensed clinical psychologist with past working experience as consultant at the University Hospital Department of Community Health and Psychiatry. In 2016, she ventured into private practice and consultancy work, a family manufacturing business, an outdoor cinema, and mobile outdoor advertising business, along with her team of experts. Dr. Kai Morgan is currently the president of the Jamaica Psychological Society, and her research interests include sexual behavior, motivation, relationship dynamics, and anything regarding Caribbean culture and psychology. Please, therefore, help me to welcome Dr. Kai Morgan as she talks to us about striking the balance in health and wellness. Dr. Kai.
Hello? Okay, give thanks, Dr. Irons Morgan. So I am going to talk today about how psychology and public health interfaces. Not seeing my slides. Okay, so one of the first things I wanted to talk a little bit about is the area of public health psychology. And we don't hear that very often. We hear clinical psychologist, we hear counseling psychologist, but the public health psychologist is extremely critical and growing. And I don't think that in any time it has been more evident about the role of psychology than this pandemic that has been facing us globally. So the public health psychologist would be thinking about areas like social isolation, quarantine, how adolescents are being impacted by staying home from school, staying at home from school, working at home, schooling from home, and all these different offshoots, economic challenges that abound based on the pandemic. So I wanted to look at our team. I'm hoping for the slides to come up soon so you can see our team at JamPsych, and then go through just a little bit of what our efforts have been. We have had on 4 levels really, therapeutic interventions. We've had workshops and seminars. We have been doing, workshops and seminars, a little bit of research as well, and a lot of alliances regionally and internationally. Sorry, I need to show you those. Okay, here we go. Okay, so this is us, our team at the Jamaican Psychological Society, from different parts of the region. So just like the Ministry of Health and Wellness, we have 4 regions in which we operate or separate into our Northeast region, where Dr. Pernell Bell is our coordinator, Dr. Venice Madden in the South, and Mrs. Georgia Rose in the West. And then we have our other members of the team, our advocacy directors, public relations director, and so on. So that's our JamPsych team. And some of our interventions had started, first one really started with a group effort. So we offered 6 sessions for frontline workers that were struggling and needing psychosocial support. So we started those. We had 40 wonderful volunteers from our membership, all counselors and psychologists who were willing to conduct these groups. So we did some of these groups, and we attached a research arm to it, looking at the pre and post feelings after group and experiences. So we haven't yet concluded that, so we don't have any results for you yet. But individually, we also, in liaising with the Ministry of Health and Wellness and recognizing that there were individual needs as well, that these same team of volunteers have been willingly offering their services for individual work for at least 3 pro bono individual sessions. So then we've also been having workshops and webinars, as I mentioned previously, and these are some of them. So in the Northeast, the Healthy Mind, Healthy Body, Best of 2020, Year of Plenty. We've had seminars on how to work from home without losing your mind. I particularly like that title. Lifelong Learning. We've looked at building resilience for our own self-care, for our own professionals, which is a big deal, a big matter in this. So we've had those kinds of webinars. We align as well, as I mentioned earlier, with the regional bodies like the Caribbean Alliance of National Psychological Associations, with whom we have a very strong relationship, offering some webinars even today and tomorrow around some of these areas. And then we have our international liaisons as well. We also have a very strong alliance with the American Psychological Association, and we are part of the Global Psychology Alliance, in which we have been doing and making a number of efforts, publishing articles and looking at and aligning and networking around the pandemic and what are the approaches that best work for all of us. So these are, in a nutshell, some of the things that we have been doing, and that is the end of my presentation.
Thank you, Dr. Kai Morgan. That is indeed what we call short and sweet. Right. And so Dr. Morgan gave us an overview of what the public health psychology approach has been like in this COVID-19 crisis, as she has led the Jamaica Psychological Society team, the JAMPSych team, in different types of responses to the challenges that we've all been facing. Issues such as social isolation, quarantine, the economic challenges, and various therapeutic interventions individually and by groups. So remember, we look forward to hearing your comments and your questions as we go along, and you can send them into the chat room. Our second presenter is someone who is very well known to all of us, I'm sure. Dr. Earl Wright boasts a wealth of experience and has served in numerous senior positions, both locally and internationally, where he has been championing the promotion of mental health. Dr. Wright is a graduate of the Kingston College and the University of the West Indies, as well as Harlem Hospital and Columbia University in New York, USA. He is a consultant psychiatrist, president of the Jamaica Psychiatric Association, and chairman of the Mental Health Technical Group of the Ministry of Health and Wellness. So we look forward to Dr. Wright's usual excellent presentation. Please join me in welcoming Dr. Wright.
Thank you very much, Dr. Hans Morgan. Striking a balance in health and wellness. Gonna look at it from the perspective, if we talk about health, we're talking of the usual definition being in sound body and mind, and that's where we hope to be. But wellness is the purposeful, enjoyable living, a deliberate lifestyle choice characterized by personal responsibility and optimal enhancement of health, physical, mental, and social. So if we talk about balancing, and this is what we do in our group meetings with members of the health team, trying to balance work, health, career, friends, family, etc., and all the different things that we do in trying to manage our stress levels. And this takes volition, and this, we have to make choices. To bring our homeostasis implies that the organism, with a certain range of psychological parameters, remain in those parameters and don't move towards physical and mental health problems. And also allostasis, implying that the organism constantly adjusts to the parameters to maintain stable functioning. So we're talking about helping individuals to manage their stress level. And usually, if you don't have any stress, then you are bored. And if you have too much, then you move into distress. So it's keeping the individual energized, focused, feeling work focused, feeling good about themselves, and not moving into the fatigue exhaustion phase. And right now, many individuals are moving into COVID fatigue, moving into exhaustion, ill health, and psychiatric care. But one of the things we know is that if you don't manage the stressors, if you don't get help in manage the stress, if you don't do it correctly on a daily basis, then you're going to run into physical and psychological problems. And one of the presenters, Dr. Williams, spoke about perceived stressors, but most of the stressors might not be perceived at all. So you have the heartburn, the rapid breathing, the cardiovascular problems, the fertility problems, the erectile dysfunction problems, and then you move into the insomnia, the immune system problems, high blood pressure, etc. So managing stress, the allostasis that one perceives is going to be important. So you don't move into get V0, moving into the anxiety problems, and they come into the primary health care with the lump in the throat, the shaking, the muscle pain, the lethargy, the racing heart, etc., etc. And the anxiety disorders, again, the fatigue, restlessness, impaired concentration, difficulty breathing. And then we move to depression. One of the most common problems in Jamaica, we know that 18% of the population will have a depressive disorder. The sleeping problems, the energy, change in appetite, and many of our people will manage their mental health problem by alcohol and drug abuse, and then moving also to thoughts of death, suicide, and irritability and anger. And it's treatable. And most of these disorders are being picked up in the primary healthcare setting and offered with the screening tools that are available and the support that's given in the community in general by a number of different programs. So we're talking about helping individuals to manage their environmental stressors, work, home, but this is also dependent on what they have inherited, their genetic makeup, and what has happened during the early stages of life. If you have had significant trauma early in life, then you are less able to manage your emotions, manage your physiological and psychological responses. Therefore, you will carry around a heavier allostatic load. And this is just a diagram of all the physiological changes that happens when there is a stressor. And remember, the only time that you're not having stress is when you are not around anymore. Any change in life at all, any change that you are adapting to, good or bad, is going to provide stress. And therefore, the prolonged neurochemical imbalance have negative consequences for the normal neural function. And there is a cost to the brain if the allostatic response is not appropriate. So we're talking chronic stress on memory, and in terms of COVID-19. COVID-19 is especially problematic because it's a chronic stressor that we have to manage. It's a prolonged stress. We don't know how long it's going to last, and it's life-threatening. Therefore, if it's prolonged, we are at a higher incidence. We're going to have higher incidence of anxiety disorders. And if it's life-threatening, we're going to have higher incidence of post-traumatic stress. So COVID is especially problematic. And many of our individuals will manage their stressor by alcohol, and therefore we have the drug abuse and drug addiction. And again, the affective memory consolidation due to stress and affecting the working memory. As we know, as everyone here knows, the stress affects the brain and therefore damages the brain, and that's why it leads to the mental health condition. But it was supposed to be normally in stress, you deal with it in a short while and you return to normal activity. You have the perceived stress, the high increase of cortisol in the body, travels to the brain, and the hippocampus shuts it down. But if it's not shut down, therefore you're gonna have the damage to the brain. And this is what we're talking about when you are over here. Now, therefore the recommendation, balancing your health and your stress and life in general to maintain healthy habits, and this conscious effort to maintain healthy habits on every day. Therefore, the encouragement that we give individuals through stress management, seminars, etc., and webinars to stay on top of their maintaining their healthy habits through calories, what you eat, exercise, routine you love, increase of water consumption, get a full night's sleep. Tracking your progress is especially important, help you to motivate, forgiving yourself on a bad day, forgiving others. And this is especially important, not only forgiving yourself, but forgiving others so you don't damage yourself and damage others. Also, the recommendation of increasing your emotional intelligence through self-awareness, self-management, social awareness, and relationship management. Because if you're not aware of how much stress you are having, where you are on the stress level, then you are not going to do things effectively to manage. And also from self-management, if you are able to manage your stressor, keeping disruptive emotions, impulses in check, add flexibility in handling change, achieving or motivating, reorienting yourself, striving to improve, and reframing to get a positive outlook. And most important, empathy. Lots of recommendations, lots of complaints from the individuals are that their supervisors are not as empathic to them as they would like them to be. Empathy is especially important, sensing another's feeling, perspective, and taking an active concern in their interests. People like for you to empathize with them so that showing that you understand. And now with the increased death levels in COVID-19, we're talking about passing it on to the next generation. If you are not doing, if there is trauma, increased interpersonal problems, then you are going to affect the emotional control in the children in the first years of life and habitual responding. So the next generation is going to have problems. So it's going to be important that the programs that the Ministry of Health have developed, that we implement them effectively so that the Reach Up program and the early childhood parenting program is able to manage these emotions, that you don't have an increased level of trauma for the next generation. Also, communication in the early years take place mainly through face-to-face communication, through the eye-to-eye contact, the vocalization, the hand gestures, the movement of arms and head, all acting in coordination to express interpersonal relationship and emotions. So that the recommendation, and I'm not sure how this is going to be implemented, is to limit screen time, because screen time is not a good way of the exchanging of communication and modeling in the early years of life. So thank you, and look forward to your questions.
Round of applause for Dr. Wright, please. In case you're just joining us, I am Maureen Irons Morgan, and I'm a consultant psychiatrist and the moderator for this panel discussion. We have heard earlier from Dr. Kai Morgan, and we've just heard from Dr. Earl Wright, consultant psychiatrist. We want to thank Dr. Wright for his very comprehensive presentation in which he highlighted the meaning of wellness as a purposeful enjoyment of life. And really want to thank Dr. Wright for all the nuggets that he gave us about balancing health, work, career, achieving that important balance, warding off the COVID fatigue, and recognizing issues of anxiety and depression, which are so common at this time. We have a lot of nuggets from him. I'm sure you have a lot of comments and questions. Please put them in the chat. And now we proceed to our third and final presenter. Dr. Kevin Goldburn is the Director of Mental Health and Substance Abuse in the Ministry of Health and Wellness. He's occupied this position since 2018. He is from Malvern in St. Elizabeth. He's a graduate of the Monroe College and the University of the West Indies. A consultant psychiatrist, he has a particular interest in drug abuse treatment. And he has completed a fellowship in drug abuse and health services management at Virginia Commonwealth University in Richmond, USA. Dr. Goldburn is a board member of the Patricia House, a drug abuse rehab facility in Kingston. He has also served as regional psychiatrist, Western Regional Health Authority, as consultant psychiatrist at the Bellevue Hospital, and as chairman of the National Council on Drug Abuse. Last but not least, he has been medical director in the medical services branch of the Jamaica Constabulary Force. So you can see the wide range of experience and knowledge that Dr. Goldburn brings to us. He is married and in his spare time enjoys football, cricket, cycling, and lawn tennis. Sounds like you have a well-balanced life there, Dr. Goldburn. Please welcome Dr. Goldburn, striking the balance in health and wellness.
Thank you, Dr. Morgan, for your kind words of introduction, and thanks the organizers for highlighting mental health as being a very important aspect of our existence, that even when COVID-19 is over, it is envisioned that we have a long-term effect of mental health issues that we have to face. So today, I'll be looking at striking the balance between health and wellness in a public health crisis, but from a system point of view. Being director of mental health and substance abuse in the Ministry of Health, I'm called upon to ensure that services still are provided in spite of the fact that we have this public health crisis. So the challenge I face when we realize we're the first case of COVID-19 in Jamaica is how can we still maintain mental health service delivery for pre-existing and new psychiatric patients, yet maintain the safety of our mental health workers? And what are the strategies we need to put in place? And what has been the lessons we learned from what we experienced? Thanks. So approximately we have about 19,000 patients across the island, and these patients are among the vulnerable group in terms of catching COVID-19 because, one, they may have cognitive impairment, so they may lack ability to reason and to remember to follow proper infection prevention control measures. They may have little awareness of the risk of this COVID-19, and they may display diminished efforts in making sure they follow the IBC measures. And also, a lot of our patients have a comorbidity of a smoking drug habit. And as related before, this pandemic-related responses may cause persons to have exacerbation of their depression and anxiety disorder they may have before, or person may become newly diagnosed with these conditions. They may be also increasing risky behaviors such as substance use and abuse of prescription medication, interpersonal violence, and there also be distress reactions of changes in sleep pattern, eating pattern. Person may have a decreased sense of safety, and of course, this may cause anxiety. May have physical symptoms, as the right explained a while ago, and also they may have irritability, and they may want to be isolated, so they may become socially withdrawn. And then, depending on how the media handle all of this, there's timely and accurate information. This may decrease anxiety level. But if the transmission of information through media exposure is transmitting fear and distress, then might heighten person's response to the COVID-19. So what are the challenges we have been facing? That many people with mental health disorders rely on the system, attending regular outpatient clinics for evaluations and prescriptions. And COVID-19 has caused restrictions due to disruption of regular clinic visits. The challenge we are facing is how can we provide adequate and responsive mental health services within the context of COVID-19. And so one challenge we faced were inconsistent medication supply. There are also a limited amount of psychiatric inpatient beds because, as you may know, psychiatric patients are treated in general hospitals and medical wards, and when they increase in amount of COVID-19 patients, they have limited space for patients who may need hospitalization for acute stabilization. And then there are times when psychiatric outreach buses have been used for COVID-related activities and make buses less available for the necessary home visits and crisis response. Then our mental health staff have had situations where they have been in quarantine and does affect their ability to provide continuous service. And then there's also a fear of doing home visits and crisis calls in areas where there's a quarantine or lockdown communities. And also there's a situation where there's a lack of adequate personal protective equipment. Then we even have situations where patients, because of fear of catching COVID-19, they want to go to clinics, whether it's at the health centers or hospitals, because of fear of catching COVID-19. So you have persons not attending clinic and running risk of decompensating and causing crisis. So at one time, I actually made an announcement on the radio that there's clinic, as you would say, clinic are keep, so they should come to the clinics and try to avoid relapse. So what are some solutions we came up with? One was to develop a COVID-19 mental health protocol, which helped persons to know how to triage patients both within the clinic setting and when they're doing home visits. So when they're doing home visits, they call ahead and assess the situation to see if anybody in the household may have symptoms of COVID and how to approach it. They also have a system as to how to decrease the flow of patients, so we make calls ahead to ensure patients who come for injection can get injection without having to stay long within the clinic setting. And there are situations where we also give longer prescriptions and longer appointments to avoid overcrowding in our clinic spaces. Then, of course, our mental health staff They also are educated on infection prevention control measures, which included donning and doffing of personal protection equipment. And then we also address healthcare workers and public, how to provide information to them through brochures, through interviews, through talks to different groups, as to how to enhance their self-care and provide support. And as Dr. Kai Morgan mentioned, we team up with them with providing webinars and also provide webinars in group settings and also individual settings. We also encourage what we call body system or peer support and also regular support team meetings within organizations and companies. And we also have employment assistance programs across the island. We provide support for staff workers. And of course, our local public mental team, with a team of psychiatrists, psychologists, social workers, also provide support for healthcare workers and the general public. Then we also have to do some specific measures because we found persons who are in quarantine and isolation, whether at home or in facilities, that they need special support. So we provide support for those persons in these settings to ensure that they, during this time of isolation and quarantine, they can be supported during that time. We have discussion with the NHF, National Health Fund, to see how they can allow for persons to get prescription filled for 3 months instead of usual 1 month. And you heard earlier about the telemental service, which improve access for service to persons who couldn't come to clinic or want to come to clinic or found difficult to come to clinic. Then we enhance our 24-hour helpline capacity by asking other volunteers from other organizations to provide backup for our regular counselors. And we established a telemental supportive network where the Red Cross will initially provide that initial contact with persons in communities and provide that psychosocial support, care packages, and where persons need more psychiatric intervention, they refer them to the helpline, and the helpline provide counseling, and if that's not sufficient and need psychiatric intervention, then they refer to persons who are in Jamaica Psychiatric Association provide that psychiatric intervention. And then especially for young people who are in quarantine, we have to come up with innovative measures to try to ensure that they could pass their time in a meaningful way. And one such measure was to have a hard NTA online course that they did while they were on quarantine. And the most recent effort we're doing is this COVID-19 community mental health response, which is geared towards training volunteers and community health aides in psychological first aid, where they can provide the initial contact with persons in community, see how they are doing, assess them, provide support for them, and where find persons are not doing well, to refer them to the mental team for further evaluation and intervention. So some of the outcomes we have noticed that some patients were not happy with the pass through the clinic, where they wouldn't get a usual time to speak with their doctor or their mental health officer. So find that a decrease in access time, they can get a chance to get feedback as to how the medication were working and how they're reacting to the treatment. But as you heard before, there's an improvement in visits to clinics, as seen in the child and mental clinics, where they did not keep appointment, drastically decreased during this time. And our helpline, you should see their number is 888-NEW-LIFE or 888-639-5433. We know that increasing calls over 100% between March and April as a result of more COVID-related calls. A person became very anxious and very distressed because of the impending situation with COVID-19 and the possibilities of negative outcome. So important lessons that we learned is that mental health is a very important part in any response to disaster or public health crisis, and also the importance of face-to-face interactions. And we also noticed about the pros and cons of remote service. Some persons find it very useful, but some persons find it very difficult to adjust to that remote service provision. Also, we know that there's a decrease in overcrowding, especially in child guidance clinic, where they can actually give patients time when they should come. We could have the clinics in manageable size, and it could be more efficiently run. Also, this situation shows a lack of adequate staff to provide psychosocial support and help us to realize the importance of partnerships. So even Charlie Brown realized that COVID-19 is not all bad. He mentioned that It cancels all sports, all bars, and make men stay more at home. So even though this may be some obstacles, but in Charlie Brown's mind, it's provide opportunities. So I'd like to conclude that epidemics expose the fault lines in our society, not only in our society, but in our health system. But we should never waste a good crisis. We should turn it into opportunity. Thank you.
Thank you, Dr. Goldburn, for that very comprehensive, excellent presentation. And I think that we can all be confident and satisfied that the Ministry of Health and Wellness has certainly been doing a lot to deal with the mental health needs of the population at this time. And as Dr. Goldburn rightly said, in this crisis, there are many opportunities, and they have certainly taken the opportunities to bring mental health care to persons where they are, either remotely or face-to-face. And they have certainly come up with innovative means. I just want to underscore the availability of the helpline, 24 hours, 7 days per week. That is novel and unprecedented. Not only the virus, novel and unprecedented. Our response to it has been unprecedented, and we are very grateful that we have a team at the Ministry of Health and Wellness, that has made such a wonderful, robust response to this coronavirus situation. And so we continue to look at striking the balance between health and wellness. And, it just occurred to me that even the name of the Ministry of Health, which has now changed to Ministry of Health and Wellness, shows that we're moving in the right direction, not just physical health, but mental and social health, and as Dr. Wright said earlier, enjoyment of living. So we want to invite questions and comments now to all three presenters. And indeed, we want to thank all three presenters, Dr. Kai Morgan, Dr. Earl Wright, and Dr. Kevin Goldburn. So we're now going to receive the questions and comments. Thank you.
Okay, so to Dr. Wright, did you say that 18% of persons will get depressed? And also, could you just explain what you meant by brain damage when you were presenting?
All right, let me go to the damage of the brain. What happens is that when you have increased levels of cortisol circulating in the blood, which happens when you are under stress for long periods of time, or when you are depressed for long periods of time, the cortisol is going to affect the hippocampus and damage the cells in the hippocampus and prevent the hippocampus cells from being, new hippocampal cells from being formed. So you are damaging the brain, it's that area of the brain, and the PET scans have shown that people with chronic depression have a lower mass of hippocampal mass than individuals who are not with depression. So we're talking about cortisol directly damaging the brain over time. And that's one of the reasons cortisol damaging the brain, the corticotropin responsing factor and the feedback loop being shifted is one of the reasons for some of the mental health conditions. And the other question about, what was the other question?
Yes, did you say that 18% of the population will suffer from depression?
Yes, most of the studies show that at any time you have a range of individuals that meet the criteria for clinical depression, and primary care has a standard, there's a standard questionnaire for depression. And if you go into the clinics, the chronic care clinics, you're going to have a high incidence of major depressive disorder. And the lifestyle survey also bore out at a high incidence of major depressive disorders the prevalence is around 18 to 20%. Sometimes more, sometimes less, depending on the population. Also, if minor depression increases in times of stress, you might not meet the criteria for major depression, but there is some depressive symptoms. And the lifestyle survey also showed that nearly a half of the population will have symptoms of minor depression.
Thank you, Dr. Wright. There's another question for you here. What's the recommended screen time for young children and early teens in light of the extensive screen time for online schooling nowadays?
Well, the American Pediatric Association recommended that the screen time should be limited, especially for children under 2 years. I don't have a specific screen time, the number of hours, but you should limit it. You shouldn't allow the child to sit all day and be in front of a screen or for most of the day, because it's the interpersonal, the relationship, the mother, father, parent, giver taking care of the child and modeling for the child, because most of the time the child might be seeing nice, bright colors on the screen, but they cannot interpret what is going on the screen. So it's up to the adult being there to interpret what is going on the screen. And children shouldn't be allowed, the screen shouldn't be the babysitter.
Thank you, Dr. Wright. There is just one more question here for our panelists. Could stringent COVID restrictions cause increased depression among Jamaicans? Dr. Wright?
Yes, you are. Yes, it's now the biology of stress and depression. If you have an increased levels of stress, and in the COVID-19 pandemic, there's no question that everybody gonna have an increased levels of stress. We were not meant to not hug one another. We were not meant not to touch our faces and decrease our cortisol levels. So when you're unable to get a hug, and I used to say that you should get at least 3 hugs per day, but you can't do that now. So other than in your bubble. So, and you're not supposed to touch your face. So your cortisol level increase. And if your cortisol level increases on an ongoing basis and you're not able to manage your stress, and if you are already at risk for depression, then you're going to have an increased incidence of major depressive disorder and the anxiety disorder. And because COVID-19 is life-threatening, because everybody's worrying whether they're going to get COVID-19 and live, or how sick they are going to get. Therefore, the possibility of increased post-traumatic stress disorder.
Okay. Dr. Kai Malgran, you may go ahead.
I just wanted to add that also anxiety, we expect, and anxiety has increased during this pandemic. And what we also find is that anxiety often leads to depression again. So from that perspective, I completely agree with Dr. Wright. We expect that it would increase mental health issues in general.
Thank you, Dr. Morgan. To Dr. Goulburn, what support mechanism is available for health workers who are on quarantine with acute depression?
Thank you for that question. So we have several support systems in place for healthcare workers who are in quarantine. We have a system where we have, in some regions, employment assistance program where persons can actually, when they know they're there, we'll interface with them, make a check-in to see how they are doing, and we'll do regular assessment based on their response. We also have had intervention from our psychological arm of the mental team in the regions who actually intervene and actually interface. And there are times when they have also called psychiatrists, depending on the level or the severity of the person's reaction. Because some persons have got very anxious, very depressed, and very suicidal, and we have to call in psychiatrists to actually go in and make an assessment and initiate treatment. So we will have a support system in place for healthcare workers who are in quarantine or isolation.
Thank you. Thank you, panelists. That's it for the questions for now.
So we've come to the end of this presentation, this session, and again, we really would like to thank our esteemed presenters. Could we have another round of applause? Dr. Sky Morgan, Dr. Earl Wright, and Dr. Kevin Goldburn. And it was certainly a very rich and enlightening session. And also, we would like to thank all the participants who have, listened and put in questions. And I'm sure you would have benefited from this particular session. I want to thank the persons who are working behind the scenes also. And at being the end of today's presentations, we look forward to tomorrow. Now, I must tell you that on your program, you would have seen promotional quiz and giveaway. There has been a little change. We will not have that today. We will have tomorrow, Mrs. Grant? Yes, so we will have that tomorrow. We won't have that today. So we want to thank you again, and we want to encourage you to log in at 8 a.m. tomorrow as we continue on the second day of our National Health Research Conference. Thank you.